Good morning, everyone. My name is Erin Papaleo. I'm the Project Management Coordinator with Care Compass Network. And I just want to welcome everyone to DBT Session 1, Building the Foundation and Putting Out Fires, Mindfulness and Distress Tolerance. This Dialectic Behavioral Therapy Level 2 3-part workshop series, oh, that's a mouthful, is sponsored and supported by the Care Compass Network's Regional Trauma-Informed Care Network team. The team consists of dedicated and passionate individuals from colleges, county government, healthcare, social care, human services, and schools, spanning across Care Compass's network's 9-county region in the Southern Tier and beyond. The RTIC's mission is to implement evidence-based and trauma-informed care by supporting the development of resilient and strong partnerships, individuals, families, and communities through the development of communities through advocacy, education, and empowerment. A core strategy to bring this to fruition is to create and promote access, availability of training, educational tools, and resources for our community. We envision a resilient community built upon strong partnerships, trust, and compassion. Before we get started with the presentation, I'd like to go over a few housekeeping items. Today's presentation is being recorded for quality assurance purposes and may be uploaded to Care Compass Network's website or YouTube page. If you do plan on sharing any real-life examples, please make sure not to include any PHI or personal information. If you are on any type of VPN network, we strongly encourage you to log off of your VPN to assist with potential bandwidth issues. We are reserving the last 10 minutes for question and answer. Please type your questions into the Q&A box, which is located at the bottom of your screen. And you may send in your questions at any time. We'll be collecting these and addressing as many of them as possible. Now I'd like to introduce our presenter. Nicole Babcock has been working in the human services field since 2001 with extensive experience working with children, adolescents, and their families in a variety of capacities, and has been a provider of mental health counseling for adults since 2013. She was introduced to DBT while working with adolescents in a day treatment program and led a DBT Skills training group for adults during her time with UHS outpatient mental health. Later, Nicole was extended the opportunity to spearhead the development of a comprehensive standard DBT program at Lourdes Center for Mental Health. She and a small team of clinicians from Lourdes completed DBT intensive training, an extensive and highly involved training process through the behavioral tech in January of 2018 with the support of Care Compass Network. Nicole served as a team lead for DBT team at Lourdes and successfully graduated 2 groups of patients from the comprehensive DBT program for adults, as well as providing team consultation for the successful graduate of 2 adolescent patient groups. She has participated in clinical and program phone consultations with a trainer through behavioral tech for the past year in order to further her practice, also with the support of Care Compass Network. Nicole has recently begun full-time private practice through her validation counseling services in Binghamton, where she plans to offer both DBT-informed treatment and comprehensive care. And Nicole, I will turn it over to you.
Thank you so much for the introduction, Erin. I'm so excited to get started today. I've put a huge amount of work into developing this training because this is a type of therapy that, having been in the field for quite a long time in this area, most therapists in this area and most providers in this area don't have access to this type of training and information on how to provide these services that are so necessary to helping the people that we serve. I know getting started in this, I felt that I didn't have all the tools that I needed to be able to serve some of the people that I was seeing appropriately because they needed more than I was able to provide. And DBT gave me a way to do that. So I'm very excited to share this with all of you today. I want to give a little disclaimer that I am not a behavioral tech trained trainer in DBT. They go through really extensive training, and I have not had that. I have been trained to provide DBT. So what I'm going to share with you guys today are my insights, having used DBT and loving the results that I get from it. And I am not from Behavioral Tech, which is the parent company owned by Marsha Lenehan. And I highly recommend, if you have the opportunity to do so and you're looking to provide a more intensive DBT experience for your patients, that you look into training through them as well. I'm hoping this will be a great jumping off point for people, and I'm really looking forward to sharing with you what my experiences have been and ways that I personally have found to make providing DBT helpful to me as a clinician and to my patients. Erin, can you go to the next slide for me? So today is the beginning of part one of our three-part training. Today, we are going to cover at the beginning a lot of information around how to integrate DBT skills into your practice. This three-part training series is focused primarily on the skills training portion of DBT, and we'll talk about that a little bit more in a minute and what that means in the bigger context of comprehensive DBT, which is a lot more than skills. But we're going to be focusing on the skills portion. It's what DBT is typically best known for. And we're going to talk about a lot of the foundational things that are important to know as you're integrating DBT into your practice. I recognize that I've put in maybe a bit more than we're going to get to in the time that we have available for covering that information. So if there are any of the slides that we can't get to before the first break, I will make sure to cover them in the next training. We are also going to be covering today skills for orientation and general skills, mindfulness skills, and distress tolerance. So we've got a pretty steep agenda for the time that we have available to us. Part two is going to focus again on more of those clinical foundations at the beginning, and then really dig into emotion regulation, which to me is kind of the meat and potatoes of the DBT skills training. Part three is going to focus on a review of the mindfulness skills in the context of interpersonal communication and the module on interpersonal effectiveness. So just an overall guide as to what we're going to be doing. Next slide. So our objectives for today, these might vary a little bit from what you may have seen on some of the advertising for today's training, because as I developed it, I realized that there were things I hadn't included that were really necessary to being able to do this work. So we're going to be working on understanding the options for delivering skills training and interventions that are suggested based on patient needs. So you can make sure that you are tailoring what you're providing to the patients you're providing it for. We're going to be working on increasing familiarity with options for integrating material from the DBT skills training manual. That's this guy. And the DBT skills training handouts and worksheets, which is also available online as well as in the Spiral Bound book. We are going to be biosocial, just for emotion dysregulation. And we're as well going to be talking about how to replace unwanted behaviors that come along with emotion dysregulation with new, more skillful and more acceptable behaviors. We are hopefully going to work on increasing your comfort with teaching and practicing the foundational mindfulness skills of Wise Mind, the what skills and the how skills. We will work on understanding how and when to apply the distress tolerance crisis survival strategies. We're going to work on the reality acceptance skills of distress tolerance. And as we go, we'll be talking about practical applications and examples of when to use these skills. Next slide. And while we're switching slides, I want to just make everyone aware that I am in a location at the moment where my internet connection is not being super cooperative with me today. I am going to try my best when I realize that things have frozen up to stop talking so that you don't miss much. And I may not always realize that. So I will be doing my best to try and keep on track and bear with the technology that is super helpful when it works and super not helpful when it doesn't. And I hope you all can bear with me today as well. Wanted to just outline our schedule for today. We're in the middle of our orientation and housekeeping information. At about 9:15, just a minute or two, we're going to be going into our clinical foundations. We're going to have a break from 10:15 to 10:25. We will have time for questions before each break, including the lunch break. So I encourage you to be sharing your questions through the question and answer portion of our program as you come up with them, because Erin's going to be reviewing those questions and giving me a heads up as to whether we should be stopping a little bit early if there are a lot of questions to address, or only allowing about 5 minutes for questions and answers if there's only a few. So we've got a break from 10:15 to 10:25. We'll hopefully cover orientation and general skills and mindfulness before lunch. Lunch is 12:10 to 12:50. And then in the afternoon, we're going to be covering all of distress tolerance. We'll have a break from 1:50 to 2 o'clock before we resume distress tolerance. Buckle your seatbelt. We got a lot to cover today, and I'm really looking forward to sharing this with all of you. Next slide. So we've got a couple of polls coming out here, and I want to encourage each of you to fill these out just to give me an idea of where you're coming from. The first is on your level of experience with DBT. And we're just looking at those results as they're starting to come in. So options ranging from I have almost no experience with DBT to I've attended some formal trainings with DBT or advanced trainings. It's looking so far like we've got a pretty wide variation in experience, which is pretty cool. I'm seeing that, you know, we've got some at either end. We've got some people who are saying that they have very little experience with DBT. We've got some people saying that they've attended at least one formal intro to DBT training. And the vast majority of people are in the, I'm familiar with some of the skills or strategies, but not much else. So I think this is really helpful to me as I look at what to focus on. And I really appreciate your feedback on this. If we can go to the next slide. All right, so we only had the one poll there, correct, Erin? Yes, so My next poll is, what is your biggest priority for today's training? Are you looking for just CEUs? This is a great CEU opportunity because it's 3 5-hour trainings that, to my knowledge, are free, which is awesome. Are you looking for some level of understanding in certain areas? Are you looking to do something more intensive with DBT in your setting? Because the way that people are going to be using this is really important for me to know as I am tailoring this to what your needs are. As some of those results are coming back, it's looking like the vast majority are looking to supplement their existing practice with DBT. So, already have some understanding, but looking for a better understanding and want to use it in some way, shape, or form. Looks like maybe we've got a couple of people who are looking to either run a skills training group or a comprehensive DBT program. For those of you who are looking to run a comprehensive DBT program, which my hat is off to you, it is so needed in this area, and it is a lot of work, speaking from experience. And it's something that's totally worth it. I'm gonna highly recommend that you use today's training as a jumping off point, and that you seek some additional really targeted training in providing comprehensive DBT, because there's a lot to it. For those of you looking to run a skills training group, I'm gonna highly, highly recommend that you at a minimum at least know the skills training manual inside and out, if not seek some additional training through behavior tech for skills training purposes. All right, that was super helpful. And I really appreciate all of your feedback on that. Looking to move on to the next slide. I'm running about 5 minutes behind my own schedule. Nothing new for me. So bear with me, we will do our best. And this is gonna be one where we're gonna get as far as we can. And if we got some slides left over, we will definitely get to them during the next training. So next slide, Erin. We're going to start with a mindfulness activity today, because this is something that is really important to start off every skills training group with. We'll be talking about that in a little bit. And it's something that we've also used in the past for starting off therapist consultation teams. It's a really important part of our practice. So you don't need anything for this mindfulness activity other than yourself. I want to encourage you to get into a comfortable position. You're welcome to have your eyes open or closed. That's totally your decision. And as I ask each of these questions, I want you to just reflect back for yourself on what the answers are. So getting started, I want you to ask yourself, what emotion are you feeling right now that feels most important to address? If your emotion had a color, what color would it be? If your emotion were an animal, what kind of animal would it be? Soul, rain, haven't had any of that lately. How would you describe that weather condition? If your emotion could tell you something, what would it tell you? And if you could tell your emotion something, what would you tell it? I want you to focus back on your breath and bring your awareness back to our training. Unfortunately, just because of the structure of our training today, we don't have the opportunity to do a back and forth discussion about what each of your experience was with this, which I would typically do after a mindfulness activity. In lieu of that discussion that I'm used to having, I'm going to share what my experience was, if that's okay. Which is that the emotion that really jumped out to me, which I thought would be anxiety, because I've been hugely anxious this morning about hoping that everything would go as well as it possibly could today. The emotion that jumped out for me was excitement. I'm really excited to share this stuff with you guys today. And that's a pretty big emotion for me right now. That came out as sunny skies for me, despite the rain that we've had. That came out as, big things. A lion roaring was the animal that I came up with. And the emotion told me that I needed to be myself and share what my experiences are, and that I needed to tell it that things were going to be okay, that we got this. So I hope you guys had a good experience with that mindfulness activity. I certainly welcome questions about that in the question and answer portion if there's anything additional that you wanted to share or ask in regards to that mindfulness. Next slide. We are going to jump right in with the foundations for integrating this into your practice, which is an understanding of the biosocial theory of emotion dysregulation and how it relates to skills training. This can be a really important thing, not just for you to understand as a clinician, but for you to explain to your patients, to your clients. I'm going to be using the word patients a lot today. I know there are a lot of different terms to use for the people that we work with. I hope it's not offensive to anyone that I'm using the term patients. It's just what comes naturally to me because of the settings that I've worked in. But this can be really helpful for your patients to understand and can be really validating for them to hear in terms of understanding why they're experiencing the things that they are and being able to name what they're feeling and what they've gone through. So in regards to emotion dysregulation, the inability to regulate emotion, which I want to clarify is not the inability to have emotion. Our goal here is not to erase emotion or to get rid of it or to lock it in a closet. Our goal is to be able to feel what we're feeling and be able to have that be within a manageable realm where we can find balanced decisions and move forward in ways that we can feel good about and that feel effective. So we're going to start with biological predisposition, which means that there is a huge range of what human beings can be born with in terms of how they experience the intensity of their emotions, in terms of their sensitivity to their environments, and in terms of being able to control impulsive urges. There are some babies that are born that cry at the tiniest thing, and sometimes at things that you don't even know are going on. And there are some babies that are just happy and, easygoing and go with the flow, and both are totally normal. When people are more prone to emotional dysregulation, a piece of that comes from that biological predisposition, that hardwiring to more intensive emotions, higher sensitivity levels, and difficulty controlling impulsive urges. We're going to combine that with invalidating environments. This is again, a whole range of things that can happen, ranging from abuse and neglect to being really, really hard on yourself. So this can be something that arises because others have a fear of reinforcing emotional behavior. So they're afraid to validate what someone is going through, which can be a very effective way of helping emotion to settle. And they just ignore it, or they tell you you shouldn't think what you think, you shouldn't feel what you feel. It's not right, it doesn't make sense to them. Invalidating environments can arise because others are under a lot of stress. They're busy doing other things. They're busy with their own lives, and it's easier for them if they just squash what you're feeling. And, you know, just do what you need to do because I really have to get this done. Invalidating environments can also occur when there are people in our lives who don't have a lot of their own emotional resources. Maybe they never had validation in their lives. Maybe they grew up with abuse or neglect or trauma that led them to not have the ability to regulate their own emotions. And they are now expecting you to make accommodations in the environment for them, and they're not able to be there for you. There's also a metaphor that I love in DBT that Marsha Lenehan uses of being a tulip in a rose garden. That if you are a tulip, you can be the most amazing, brilliant, beautiful tulip there is. And if you were planted in a rose garden, you're never going to look like a rose. And in fact, all of the efforts of all the roses around you to get you to look more like a rose are going to take away your tulipness, are going to make you look less like who you actually are. So that poor fit may have nothing to do with poor intentions or being out to get someone or wanting to see them fail. It can be the opposite. It can be wanting them to be what someone thinks is the best for them, when in fact, it just doesn't match with who they are as a person. So making unrealistic demands on someone based on who they are and what their strengths are can really, really impact their confidence level and their ability to act effectively. Ineffective environments are one that I frequently forget to talk to people about, but ones that are really important to keep in mind. Because ineffective environments might mean someone has the best of intentions, that they really want to do the right thing, and they might not know what to do in order to be effective in helping someone learn to manage and regulate their emotions. So they might not respond when someone responds in an effective way. If I ask, can I do that? They might ignore me. They might, say, no, not right now, I'm too busy. And it might take me building up to a level of, blowing up. Why can't you listen to me? That gets them to respond, which means they've just reinforced that I need to blow up, that I need to have that really intense level of emotion in order to get a response from them. That's an ineffective environment, because that's an environment that's teaching me to have dysregulated emotion. Manipulation isn't necessarily going to cause long-term problems with dysregulation. What is going to lead to long-term problems with dysregulation is the transactional effect, the interaction between our biological predisposition, an invalidating environment, and ineffective responses from the people around us. This is something that takes place over time. This is not something that typically develops out of 1 or 2 interactions with someone, although trauma can play a big part in this as well. And some of those bigger traumas can absolutely affect our emotional dysregulation. The way that this fits in with skills training and why skills training is so critically important as a part of effective treatment for emotion dysregulation is that skills training gives us effective responses that we can use when we wouldn't be sure otherwise what the heck to do to make things better. It also, in turn, when we practice those skills, impacts our environment because it gives us the opportunity to express our needs in a way that's less dysregulated. And it gives the people around us the opportunity to see us responding differently and not just blame us for those big reactions and ignore our needs. So there's a transactional effect that also happens when we start building skills and behaving more skillfully that can impact our environment, and that really is helpful in getting the environment to, in turn, reinforce us more effectively. It's like it creates a flywheel that once it gets started, can keep itself running. I'm gonna move on to the next slide. Review of DBT basics. There are 3 different modes of delivering DBT that I want to reference and that I want all of you to keep in mind as options when we're talking about DBT. Because when we talk about DBT, it can look like a lot of different things. Standard and evidence-based DBT, which is what the majority of the research has been done on that makes this an evidence-based practice, is something that includes 4 critical components. Skills training is just one of them. And this is really important to recognize because there's a lot of skills. It's hard to imagine there could be anything else to do in DBT besides the 50-some skills that we're going to be covering. And there totally is. There's a lot to DBT. So structured, standard, or comprehensive DBT includes structured weekly individual therapy, which is not your traditional CBT-based therapy. It is very, very structured in the way that we follow the diary card, the behaviors that we identify, the targets that we follow. There's just a lot to it. Standard DBT also includes a weekly skills training group that has a facilitator and a co-facilitator, both of whom have very important roles, which are different from one another. And this is something that can be a huge issue in clinic settings. Honestly, in a lot of settings where there's a need for accountability of billable hours, because now you have 2 clinicians tied up in providing this group where it would be certainly more cost effective to have one. A metaphor that I've used in the past in describing this is if you choose to run a skills training group with just one facilitator, it's like choosing to play a baseball game and say, am I going to have a pitcher or a catcher? They do really different things, and they're both really important. DBT skills training can be offered individually, and we'll be talking more about that in a few slides. Standard DBT is offered in a group, and you do lose some of what I call the DBT magic, because there is just a synergy that happens when people who are having similar struggles are in the same room, hearing the same things at the same time, and can get vicarious validation when they hear someone else who has a similar struggle, find ways through that, and hear that they're not alone in that. Standard DBT also includes 24/7 phone coaching, which is a little daunting. I know it was for me, a lot daunting actually, when I first started doing comprehensive DBT. And this is also why a team is so important for comprehensive DBT, because one person being on call 24/7, 365 is not practical or realistic. The idea here, which we'll talk more about in a minute, is that comprehensive or standard DBT is something designed for patients who have the highest level of clinical acuity, patients who are going to be acutely suicidal, who are going to have self-injuring behaviors, and these types of behaviors don't just occur during business hours. So the idea is to be able to provide 5 or 10 minutes of phone coaching. We're not talking hours and hours on end. We're talking 5 or 10 minutes, unless it is truly a life-threatening situation. And being able to get them through that in the moment, rather than allowing things to spiral out of control until business opens the next day. So that's standard DBT. That is not what most clinicians here are going to be looking to provide. Skills training only is also evidence-based, by the way, but for different things, because it misses a lot of the key factors that are present in standard DBT. Skills training only involves a weekly skills training group with 2 facilitators. Again, can be offered individually if it's appropriate. Participants need to be engaged with an individual therapist outside of the group who is willing to coordinate care. This is really important so that there is someone to go to for really personalized application of skills that isn't always possible in a group setting, or to address how to apply this to different situations. There is still recommendation for a weekly therapist consultation team for the skills trainers, because this is hard work. There is support that's needed around this. And there are things that can come up that you just would never imagine in your wildest dreams. And you need to process this and figure out how to get around it and how to be more effective when these things do happen, rather than just stuffing it down and doing the things that we're trying to teach our patients not to do. There is less extensive training that is required for skills training only, and it's still pretty darn intensive. The last type of DBT that we'll talk about is DBT-informed treatment. And it can look like a lot of things, but this is the addition of DBT skills and concepts to the treatment that you're already doing. So something to supplement, not something as a foundation of what you're doing. There's a lot of good therapy going on in the community right now, and DBT is not the only way to do things. And it doesn't mean that there can't be bits and pieces that you take out of DBT that really speak to you, that you think your patients could benefit from, that are going to still be beneficial. So it uses a combination of skills and strategies from DBT. It may allow a consultation team, which we're going to talk more about. And important, very critical to be aware that the effectiveness of taking bits and pieces of DBT and plugging them into existing practice is not evidence-based, which just means that it's not been researched, because different people have really wildly different practice styles and different clinical foundations. And the pieces that you use are only going to be as effective as you make them. So I bring this up because it's not realistic to expect that if you take bits and pieces of DBT and plug them in where you think would be helpful, which is still awesome and great work and things that can be really beneficial to your patients, it's not realistic to expect that you're going to get the same outcomes that your patients would get if you were using a full standard DBT with all 4 components, which is what the evidence is based on. I'm going to move on to the next slide. I know I'm throwing a lot at you guys. Want to talk a little bit about targeting your audience. I'm not going to dive too deep into this, and I think it's important nonetheless. So want to frame that treatment, as you all know, always starts with a really thorough assessment of diagnosis, risk factors for safety, history, and current strengths and needs. And an appropriate foundational assessment is absolutely critical to make sure that you are matching the person you're treating with an appropriate treatment. Because I can meet someone the first 3 times and think, oh, they've kind of got it together. I think I can just throw a couple skills at them and they're going to stabilize right away. This is going to be okay. And actually, if I do a more in-depth assessment, which those of you who know me know that that's something that's really important to me and that I will spend a really, sometimes ridiculously long time on, once you do a deep dive, sometimes you find out that, oh, there are some huge traumas in this person's background that are absolutely impacting how they are functioning right now, and that they're just doing a really good job of being highly avoidant of. And there's a good chance that if I start teaching some of the emotion regulation skills or the interpersonal effectiveness skills, things could unravel really fast if I don't have a super good foundation of the distress tolerance skills first and the mindfulness skills. And I need to be aware of the ins and outs of, you know, what to address with people and what are things that I need to not touch a whole lot right now, because let's review, DBT is not indicated as a primary trauma treatment. DBT does not address trauma directly. DBT lays a foundation to help stabilize moods and behaviors in order to be able to do effective trauma if it's needed, which can sometimes be done concurrently once those behaviors start to stabilize, and sometimes needs to be done sequentially after DBT is completed. So doing that really thorough assessment is very, very important. Standard DBT is going to be most highly suggested and recommended for patients who experience life-threatening behaviors. We're talking suicide attempts, suicide crisis behaviors, such as, you know, cries for help. I'm going to kill myself. Oh, I'm going to go find some pills. You can't tell me what to do. Those types of behaviors are behaviors that get super scary for therapists. And those are types of behaviors that really need a standard DBT type of treatment in order to contain them as safely as possible. Deliberate self-harm or other imminent life-threatening behavior. DBT in a standard form has also been used really successfully for substance using populations, for eating disordered populations. And there are tweaks that are needed to the curriculum to specialize it towards those populations. I'd encourage you that if those are populations that you are working with, that you look into more specialized DBT treatments. There is an SUD, substance use disorder for DBT curriculum. What I'm not less familiar with is the eating disorder curriculum for DBT. And I can also tell you that I've used DBT in its standard form with a lot of people who have concurrent eating disorders and some of these other behaviors with some pretty good outcomes. Anyone who has serious therapy interfering behaviors, so just not showing up to sessions on the regular, not being present in sessions, dismissing the value of sessions, behaviors that interfere with the therapist's ability to treat the patient. This is a hugely important one in DBT because some patients come in and they push every one of our buttons. And this drastically decreases our willingness to provide what is a very difficult type of therapy to provide to begin with. These are patients that we need a therapist consultation team to help us treat effectively. Patients who experience severe quality of life interfering behaviors, so really severe or incapacitating mental disorders, extreme poverty, deprivation, or homelessness, criminal behaviors with imminent risk of jail, domestic violence, or difficulty controlling their own behavior with serious consequences are all types of circumstances and behaviors that warrant a standard level of DBT. Severe skills deficits or significant difficulty regulating intense emotion can also make patients really appropriate for a standard level of DBT. If they don't know what the heck to do 90% of the time, and they want to, and they just can't find the right things to do, standard DBT is going to be really, really helpful with that. Standard DBT, I also want to note, can be provided either on an inpatient or an outpatient basis. There's a great book on providing DBT in different settings that can be really helpful. I can pull that out probably after the break and have the name if anyone is interested in that as well. For people who have PTSD, which is an indicated diagnosis for standard DBT, standard DBT plus an evidence-based trauma treatment protocol. So either the DBT PTSD protocol or prolonged exposure therapy or other types of evidence-based trauma treatment are most highly recommended for treating patients with PTSD who also have a need for DBT. Skills training only is going to be suggested for people who do not meet any or most of the above criteria, who do experience mild to moderate disorders that are unlikely to respond to treatment as usual without systematic and consistent exposure to new coping skills, or for whom symptoms are likely to worsen without consistent and systematic skills acquisition. So there is also evidence to support benefit of skills training only for people who are on a waiting list for standard DBT. There is benefit there if they can't access standard DBT right away, and it's better than nothing, and it's not going to treat everything. You would not have hardly any DBT, and being able to provide a skills training only option absolutely is beneficial, but is not going to address everything that patients might need in order to benefit. DBT informed treatment is going to be suggested for people who don't meet any of the above criteria and who have symptoms that are stable enough to learn skills as needed in a piecemeal style. So they're not going to need to know every single one of the distress tolerance skills in order to stabilize their symptoms. Maybe having one or two of the skills would be enough to ground them so that they can do more of the work safely. So we want to be looking for patients for whom there is not significant risk of symptoms worsening drastically in the meantime, if we're going to choose to do this in more of a piecemeal style. Next slide, please. And I just want to acknowledge, I'm so sorry that things keep skipping in and out from my end. Because we had some technical difficulties early on and I wasn't able to be in control of the slides, I can't necessarily see when things are freezing from my end. So I'm going to do my best to be sensitive to that, and I may not always know when that's happening. Let's see. Group skills training versus individual skills training. This is going to be really important for a lot of you, because not all of you are going to have access to teaching skills in a group setting, especially with two co-facilitators. So group format for skills training, like I said, two facilitators, and it's going to follow a preset curriculum, which we're going to be referencing as well in some of the future slides. It is evidence-based, whether it's through standard DBT or skills training only. So group is always going to be best if it's an option, with just a couple of exceptions. So skills training in a group format is skills focused, and it's going to be closer to a classroom setting in nature than a more process oriented group. I always tell people going into group, this is not sitting around with a bunch of complete strangers and telling them your life story. This is sitting down and participating in a class and learning skills. This is going to allow for a really systematic skills acquisition, so that if one or two people are just having a super off day, they're not able to be present, they're in and out of the room, the rest of the people are still learning the skills. And you know, one of the mantras in DBT skills training is just keep teaching. So the co-facilitator is going to be addressing all those people who are bouncing in and out, who are having a hard time attending, while the primary facilitator is just going to keep teaching. This allows for people to continue acquiring skills despite other things that are coming up, and despite things that might prevent them from learning skills otherwise. It also allows for some social cues that are going to facilitate learning. When someone who's really reluctant to learn skills sees other people being really excited about them, they're going to be more apt to engage and buy in themselves. It also, as I spoke to earlier, is going to provide opportunities to interact with others experiencing similar issues in a safe setting. So another critical job of the facilitator and the co-facilitator is to create a safe setting, to really orient patients to what goes on in group and to what is appropriate and inappropriate group behavior, that we're not going to be making direct attacks on other people. I'm getting ahead of myself here because this is in some of the future slides, but having a safe environment and creating a common language around DBT can really build cohesiveness and a sense of belonging. It gives the opportunity for people to practice skills. If I'm sitting in a room with one other person, they can only practice skills with me. Being in a group setting gives them the opportunity to practice skills with my co-facilitator, with all of the other participants. So this is important to be aware of as well. Let's see. individual structured skills training is typically going to follow the same curriculum and the same session structure as a group skills training, but we're only going to have one facilitator and one participant. This is, in essence, individual therapy. This is something that I bill as individual therapy, and it's skills training in an individual therapy format. It is ideal for people who are not appropriate for a group setting, either because of unsafe behaviors they just cannot control, either being nasty and hurtful to people or being physically harmful to people, or for people who work weird hours or just can't be available to attend group. And especially under pandemic-related precautions. I know behavioral tech came out with some recommendations around providing group over Zoom in a group setting during the pandemic. For me personally, that was just something I couldn't wrap my brain around. And I ended up providing individual skills training to the small handful of people I had, especially because I didn't even have enough people just starting up a private practice to offer group to begin with. So I've done a lot of individual skills training with people because of the pandemic. It is a way to offer skills training if there's no group that's currently active that your patient has access to. And a benefit is that it does, and this is also an Achilles heel, is that it does allow flexibility to tailor your curriculum and pace to match the needs of the person that you're working with. If you've got someone who's a slower learner or who needs more specific examples in order to learn things and has more time than what it takes to get through the traditional DBT curriculum, which for adults is a year. It's a long time. And if they're willing to make a bigger time commitment, sometimes you can spend more time on those skills and you can really tailor things to what people's needs are. It also has greater potential to kind of go off into the weeds and to get away from learning skills every week, which also has its own downfalls. So it's important to weigh both as you are deciding how to deliver DBT. Skills can absolutely also be taught piecemeal as needed in DBT-informed treatment, whether that's individual or group therapy, if you've got an existing group of some other nature. So this approach, again, is not evidence-based. It is not recommended as a primary treatment intervention for high-risk patients who have significant skills deficits and who have risk of symptoms really worsening and becoming very risky if they don't get some skills ASAP. That said, it can be really, really helpful as a supplement to your existing work. We're going to move on to the next slide. Erin, would you be able to move us to the next slide? Awesome. Thank you. All right. So some guidance around facilitating skills training groups. They're going to be, as I said, really similar to a classroom setting rather than a group setting. You're typically going to have tables or desks of some sort where patients can set their materials. You're going to encourage them to take notes as you're talking and discussing things. It is oriented around the centerpiece of teaching and practicing a preset curriculum. And personal information is only going to be shared in the context of learning and practicing skills or inviting feedback for how skills could be applied. So there is sharing that happens. There's absolutely a lot of sharing that happens. The purpose of great specifics in the skills training manual around how to deliver skills training groups and the mechanics of doing it, pages 3 through 122. I highly encourage you to check this out if this is something that you plan on doing in a group setting. Again, also highly recommend specialized training through behavior tech. I cannot say enough about how amazing their trainings are. They are intensive. It takes a pound of flesh to get through it because it's really intensive. It's like going back to grad school. And I don't think anything else can take the place of doing that. So if you have the opportunity, please, please take it. Important to be aware that some insurances, namely from my experience, Excellus insurances, managed Medicaids and Blue Cross Blue Shield, are only willing to reimburse for group psychotherapy for DBT skills training under very specific diagnostic, behavioral, programmatic, and clinician training criteria. Please check your patient's insurance, and please check with the insurance guidelines and regulations that are updated fairly frequently. At the time that I started the program at Lourdes with our group there, it was required that at least one person in the clinic have completed either an intensive or foundational training through behavior tech in order for a comprehensive or skills training only group to exist and be billable within that clinic. That said, other insurances don't necessarily have those same regulations, so please check with your patient's insurance. In an outpatient setting, group psychotherapy, which is the 90853, is only going to reimburse you for 60 minutes of group. Traditional skills training group under standard DBT and under skills training only is 2.5 hours with a 15-minute break. That is a lot of group. And that is way above and beyond what is reimbursable. Insurances have told me you can meet as long as you want. We don't limit the amount of time that you can meet, and we're not going to pay you for more than an hour. This can present some humongous limitations financially and logistically, and I encourage you to really look at the pros and cons of offering a shorter or a longer group and how that might affect things, because despite the fact that they will only reimburse for an hour of group, they also still expect you to get through the curriculum in the amount of time in evidence-based practice, which for adolescents is 24 to 26 weeks, and for adults is, I believe, 52 weeks, 48 to 52 weeks. So be aware of these things, weigh the pros and cons, and look at some different options for how you can deliver this. COVID has absolutely impacted DBT groups. And this is a critical treatment for our patients who have more intensive needs. I really encourage you to find a balance, a dialectical balance, recognizing that both are important in terms of delivering skills and being safe and cautious and using good safety measures while delivering skills training during COVID. Zoom is an option. I encourage highly that people be very aware of people moving into the background, other people who might be present during the training, and confidentiality. I also encourage you to be aware of only using a secure program for your groups, because confidentiality is exponentially more important in a group setting. And being aware of the time. Erin, I'm wondering if you can do a quick flip through for me of the rest of our slides until we get to the question portion, so I can see what else is needed. I will be covering the rest of these slides in our future trainings. Wow, there's a lot that I didn't get to. All right, we will get to them, I promise. And this slide deck will be available to people if you want to look at those slides on your own. There's a lot of what I was planning to talk about with each of them that you won't necessarily get just from reading the slides, but it might be a good foundation to at least get you started between now and our next training session. I also want to orient people briefly. We are going to be doing a 10-minute break from 10:15 to 10:25. We're getting into questions right now. For the remainder of our training, I ask that you have access to your DBT Skills training handouts and worksheets, whether through electronic form or paper form if you've printed them out, or through your book. Just because of licensing and not wanting to do anything that I shouldn't be doing, and I'm shooting myself there, and we'll be talking about that as well. But anything that I question whether it might be legal or not to do, I am not going to be showing these handouts on my slides or in my training. I will be talking about them. So I encourage you to follow along through your own copies as much as possible. We're gonna get to the questions now. It looks like we have 3 questions. And I'm just gonna go in order of how they arrived. And actually, I'm going to read all of these out loud, and then I'll do my best to try and manage my time and respond to them. First one says, when I recommend a group to clients, I often get the cringe and head shaking. How do you recommend we might better encourage our clients to engage in DBT group? This is a fantastic question, Brittany. Thank you so much for this question. This is so common. So I'm going to answer this briefly, and then I'll move on to the next 2. Being able to have some metaphors that you can use with your clients that you think they will relate to and buy into can be really important here. So being able to have a metaphor, if you've got a more sports oriented client, of, you know, this is learning how to pitch, this is learning how to catch the ball, this is learning how to hit the ball and going to batting practice. And if you went to play in a baseball game and expected that you were going to do really well, and you've never learned how to pitch or catch or hit the ball, how successful can you expect to be? That is one example. I want to encourage you to really find metaphors that your patients can relate to, and be creative with that. I also find that doing some really intensive orientation for people before they start group can go a long way toward buy-in with group. And that was one of the slides I was going to address today. I apologize, I was a little long-winded. We did not get to it, and we will. But the more that you can give them an accurate picture of what group will look like, and the less that they can make things up in their head about what they think it will look like, the more willing they are to try it. I hope that answers your question and that that's helpful. I certainly invite further questions on that if needed. Next question is standard DBT receiving patients. Must patients meet all the criteria you mentioned, or can they have one or any combination of the behaviors or skills deficits? I'm going to say it depends. A big piece of this, I'm sad to say, goes back to reimbursement. Excellus has some very specific criteria around what criteria patients need to meet in order for them to receive standard DBT and for you to be paid for it and not have them take that money back in the future. That said, one or more mean that they have to have standard DBT just because they've got one or more if they're one of the lesser intensive things. So I know I just froze there. If they have one or more, yes, they would be appropriate so long as their insurance authorizes it. If they have more than one, great. And just because they have one doesn't mean that they can't do a lower level unless it's a really like life interfering behavior, that a lower level of treatment necessarily wouldn't make sense. So let's see, I'm looking at questions. What suggestions do you have for enhancing the effectiveness of DBT-informed treatment when that is the only option for patients? So there's no formal DBT skills training or standard DBT available. Couple of different recommendations here. I'm going to recommend that you look at the curriculums that are in the skills training manual. And those are going to be referenced in the slides, how to find those. You can also look them up in your manual yourself. And for people who really could benefit from a higher level of care, making sure that you are teaching the skills in order and not missing any skills is going to be more important. And maybe toggling between, if it's a patient who can tolerate it, like half the session is normal therapy and half the session is skills training, or every other week you're going to go back and forth between regular therapy and skills training. There's a lot of different ways that you can do this. So for this part, I'm going to really try and buckle up, hang on your hats, because we are going to do our best to get through all of these slides before the end of the training. I want to make sure that you guys can get exposure to all of the skills today. So I'm going to do my best to pace myself, and we'll see where we can get. I do want to reference briefly that from some of the things we didn't get to in the first portion of the training, one that is very important to be aware of is that the handouts and worksheets and the skills training manual are evidence-based for practice with adults. There is a curriculum in the skills training manual for adolescent use, and best practice for use with adolescents is actually use of the, I believe it's the Rathison-Miller DBT for Adolescents book, which has all of the handouts and worksheets, as well as the skills training manual in one book. And they're going to be a little different, and some of the skills are going to be it's slightly changed from the way that they're presented in the adult curriculum. So if your primary population is adolescents, I really highly recommend that you pick up a copy of DBT for Adolescents, and just wanted to put that out there for anyone who might be working with that population. I've jumped the gun a little bit, and I apologize because of the technical difficulties that we're having. I don't have access to be flipping through my slides and seeing where we're at, so I'm going off of memory. I was supposed to wait on this poll till the end of this section, and we did it now. So I appreciate you guys responding. This is a poll on mindfulness, and we're actually going to start with orientation and general skills, and that is okay. But you guys said that the vast majority of you do some mindfulness, but want to strengthen your practice. So that's pretty cool, and a little bit of a smattering elsewhere. And looks like the vast majority of you already have a practice there. So that's awesome, and we will fly with that when we get to mindfulness. So we're going to start out with, I'm clicking like I can move my slides, that's funny. We're going to start with orientation and general skills. We're going to start with handouts 1 through 4 in the general skills of your handouts and worksheets. We are going to skip number 2, just because it's not used in the standard curriculum. It's there though, if you would like to use it. So general handout 1, goals of skills training. This is great as an orientation to addressing problems that people are experiencing as behaviors. DBT is a behavioral treatment, hence the B in DBT. It is really important to orient patients as often as possible to the idea of what they're experiencing as a behavior and not as some inherent part of their personality that is unchangeable. So we go back a lot, and this is a huge focus in structured individual DBT when we talk about target behaviors. But in skills training as well, we talk about behaviors to decrease and skills to increase. Important for you as a clinician and for you to orient your patients to as well, that when we talk about behaviors in DBT, we are not just talking about things that a video camera would be able to pick up. We're not just talking about physical actions and facial expressions and sounds we make and words we say. We're talking about behaviors and functions. So when we say behavior in DBT, we're actually referring to all 3 of those things. The behaviors to decrease section of handout 1 is going to really encourage focus on identifying behaviors that interfere with progress towards people's goals, as well as being able to develop realistic expectations of what skills training can help with. Because skills training can do a lot, and it's not a cure for cancer. It's not a cure for being born into a family that you wish you weren't born into. It can only go so far. So getting clear about what behaviors we're looking at decreasing is important. Skills to increase section is going to outline the 4 major modules of standard DBT. So we're going to be increasing skills in mindfulness, interpersonal effectiveness, emotion regulation, and distress tolerance, but not necessarily in that order. And I'll talk more about that. Actually, I can talk about it now. They're not arranged in the book in the order that we teach them. They can be taught in any order, and that is because if you have an ongoing DBT group, typically you're going to be adding new patients at any mindfulness module if you have openings. So people are going to start at different places. And ideally, you're going to teach mindfulness. Well, you're going to do general skills and orientation and mindfulness together first. You're going to do distress tolerance second, because those are the skills that help people get their feet on the ground so that they can use some of the more complex skills. Then we do mindfulness again, and then we do emotion regulation. And then we do mindfulness again, and then we do interpersonal effectiveness. And that is one full round of DBT. Adolescents are going to have an additional module called Walking the Middle Path. I love the personal goals section of this first handout. This gives patients the opportunity to identify their own personal goals for behaviors that they have that they would like to decrease, and skills that they would like to increase in order to help get them closer to those goals. This can be a really daunting task for some people. And what's really important in DBT is we talk about DBT as it's not a suicide prevention program. It's a quality of life enhancing program. It's something that's meant to help people develop a life worth living, not just to get rid of unwanted behaviors. So a big piece of individual structured DBT is being able to help patients identify their life worth living goal, what they are working towards, and what would make their life feel more fulfilling and like they want to be present for it. And starting from that life worth living goal and then working backwards, it can sometimes be easier to identify, well, what's in the way of getting to that goal? And what behaviors do we need to work on decreasing in order to remove barriers to achieving that goal? Not every patient is going to have an easy time identifying a life worth living goal, and it is not imperative that they have one in order to make sense of this handout or to benefit from DBT. Sometimes just working with what they've got, which might be, well, I don't want to feel the way that I feel. Well, if you didn't feel how you feel, how would you want to feel? And starting from there. So I gave an example here. I have a pandemic puppy, was not intended as a pandemic puppy, has been a goal of mine entering into private practice to be able to have a dog that I could use in therapy, because that is another passion of mine, is animal assisted therapy, which is just a whole nother really cool thing and something that I hugely enjoy. So I've got a puppy, and my puppy is about 6 months old, and my puppy is a little wild and has a hard time settling and has lots of really normal puppy behaviors. And not all of those are really super conducive to therapy. Like, puppies bite and puppies jump around and jump on people and chew things up. And that doesn't look real professional in a therapy setting. So my life worth living goal right now, one of them, is to be able to integrate my puppy more into therapy sessions in a safe, appropriate, and beneficial way that doesn't make me feel like I'm being unprofessional. Because people love puppies and people don't love being bitten by puppies. So my behaviors that I'm working on decreasing in order to work towards that goal are having unrealistic expectation of my puppy's behavior. So if I expect that my puppy is going to come in and act like a 5-year-old trained therapy dog, that is unrealistic. And I need to decrease my expectations of what she's capable of based on what's realistic right now. I need to work on decreasing my urge to skip walks that might help her burn off excess energy. When I have phone calls to return and I've only got so much time between sessions and I have a choice between eating lunch or taking my puppy for a walk, sometimes I have an urge to eat lunch. And skipping walks is almost never a great idea if I want to have a puppy who is somewhat manageable during the day. Another behavior to decrease is feeling shame when I think that others are judging me if her behavior isn't perfect, because I have an idea in my head of what I think her behavior should look like, and that might not be at all what they're looking at. It might, but that shame gets in the way of me being able to be effective. So my skills to increase in working on this are radical acceptance that she is where she is, which is a distress tolerance skill, pros and cons, and the effectively skill for whether or not I'm going to go on walks and what's going to be effective. And mindfulness of current emotions, check the facts, and opposite action, which are all emotion regulation skills to help address feelings of shame if she's not acting like a model citizen all the time. So I hope those examples are helpful. If we could go on to the next slide. Options for solving any problem. I love this handout. I often reference this handout. I think in the curriculum, it is referenced as an optional handout. It is a starred handout, which means it's got a little star at the top that says that it's part of the standard curriculum. And I'm actually trying to look up in my manual right now whether it's actually a part of it or not. Yes, it is listed as an optional handout. I usually use it as a standard handout. This handout is great for reminding patients that they have options, even when they're not options that we would choose or that they would choose. And recognizing that they have options can help make an unpleasant situation a lot more bearable and tolerable, so that we don't feel backed into a corner. It helps to identify that not every one of these options is going to be possible in every situation. I can't solve every problem, which is number one there. There are some problems that I can't solve. And, then I've got maybe 3 options, but still recognizing that there are some options that I do have make a difference. Or possibly make it worse, because you know what, we're human, and sometimes we need to wallow in things, and sometimes we do things that make things worse, and we either don't intend to, or we're just so far in emotion mind that we don't care. And that is an option, and it's rarely a great option, but it is an option. Recognizing that staying miserable is an option can sometimes motivate people to use one of the other options, because where they would go to being stuck otherwise, if they can recognize that that's not a helpful thing, and you're actually suggesting that I do this unhelpful thing, obviously don't tell them like you need to stay miserable, but the idea is, well, it's an option. What do you think is going to work best? Can create motivation to do something different. In option 2, the idea of feeling better about the problem is not suggesting that you just suck it up and move on, or that you stop feeling the way you're feeling, because those are not realistic expectations, and it is not possible to just will yourself to feel differently than how you feel. It is an invitation to acknowledge how you do feel about the situation, and then use emotion regulation skills to decide what makes the most sense so that you can arrive at a different emotion. There is a big, big difference between sweeping your emotions under the rug or shutting them off and acknowledging them and then doing something effective about them, which allows them to complete that cycle. Let's see. The items at the bottom of this page are just going to address the skills that we use to do each of those options for solving any problem. And go ahead, Erin, to the next slide. Let's see, handout 3, guidelines for skills training and the patient contract. These are the standard guidelines for DBT standard skills training groups. If you work in a program where you're going to have needs that might differ somewhat from these guidelines, in my experience, it has been totally okay to create a different contract to use in its place. This is also even if you're not using it in a group setting, as a way to orient people to what to expect in group and how to behave in group. It can also be really helpful to use in a one-on-one setting, because orienting people, if you're deciding together that you're doing a structured individual skills training, orienting people to what's going to be helpful, what's going to be not helpful, and what's expected of them can also be really important. Being clear with people and orienting, I cannot say that word enough times, orienting to what is expected of them ahead of time is exponentially kinder than addressing or punishing or having some sort of aversive consequence when behaviors arise that you're not okay with. So giving someone every opportunity to do the right thing is what we're looking for here. I always, as a practice, meet with patients, even if they're not my own, one-on-one for at least one session, even if it's a short session, before they join a group or before I do individual skills training with them, in order to review the guidelines for skills training or my own personal skills training guidelines and patient contract. I've given you guys some ideas here of things that I have altered about this in my own skills training patient contract. I use pretty much everything that's here, and what I add to it are, when I worked in a clinic where we had discharge guidelines based on attendance, because the clinic couldn't stay afloat if people were just no-showing all the time, and we had 2 facilitators running a group with 2 people in it. So we did have discharge criteria if someone missed a certain number of groups, and orienting them to that ahead of time was really critical. Orienting them to how late arrivals would be handled, that you're not just going to barge into group in the middle and make a fluster and whatever. We're going to have you meet with a co-facilitator outside of group. They'll let you know where we're at. They'll bring you in at a helpful time that's going to be least disruptive to the group. You might need to review some of the handouts that you missed afterward in individual therapy or after group. And because of the settings that I've worked in my personal training, I do not allow for attendance when people are under the influence of drugs or alcohol. Standard DBT actually does and actually encourages that, because of the idea of not that people use, but that if people are already under the influence, that they not skip skills training because they're under the influence, so long as they can act clean and sober. Because of the importance of generalizing skills to situations where they would need it. And if it's someone who's going to be drunk or high regularly and is struggling with addictions, they need to know how to use those skills as best as possible while they're using. I don't work in settings where that would be appropriate. And if you do, that may be something that is important to address as well. I personally also really over-oriented patients around contact through social media, picture taking, and use of cell phones during group as it relates to confidentiality, because people feeling safe in group and feeling like their picture is not going to end up on Snapchat or Instagram or Facebook is really important. So, addressing what's okay and what's not okay in that regard is critical in my mind. Addressing the difference between venting and appropriate sharing in group is important. And I will give people examples of this and discuss it at length. Addressing how to appropriately respond to other group members if they contact you in crisis, that you are not expected to be their therapist, that you should refer them back to their therapist or to 911 or to CPEP if they are in acute crisis, that your only role is to refer them back to them, to encourage them to use their safety plan, and maybe to call 911 for them if they tell you that they've already overdosed or done something really dangerous, and that behavior has already occurred. But you are not to keep secrets from people. You are not to take on that responsibility of solving their problems for them. And to provide guidance on how to manage aggressive or destructive urges safely and appropriately during group. So asking that people leave group to go to the restroom, to take a walk around the building, if they need to cool off, if they need to talk to the co-facilitator for a few minutes in order to help them use some skills to ground themselves. These are all things that we ask people to do, and then to return to group when they're ready, in order to keep group safe. And also addressing that it's okay to disagree with other people. It is not okay to attack other people for having opinions different than your own. All right, next slide, please. Skills training assumptions, and I'm just looking at where we are at for our timing. We're doing okay. So for skills training assumptions, I like to review these all out loud with participants and allow some time for discussion. There's some stuff here that can get some pretty big reactions from people. The assumption that people are doing the best they can, and tell me that my mom is doing the best that she can. Or you can't tell me that, you know, my partner who is being abusive is doing the best that he can. What can be helpful here is to frame this, that given the context of what each individual person's experiences have been leading up to that moment, they may be doing the best that they can given those circumstances. And sometimes zooming that lens in to ask that they at least acknowledge that these are assumptions that will be made by skills trainers about participants, and assumptions that we ask participants to make about one another within the group, at a minimum, can sometimes be helpful in getting them to have a little bit of buy-in with these. My personal experience has been that applying these universally can be really helpful. When we're looking at applying skills to manage our circumstances, but it is only necessary to ask participants to apply them to other group members and facilitators in order to begin practicing skills. All right, where are we at with the slides, Erin? What's next? Wow, we are 7 minutes early. I'm kind of amazed. So I want to reference as well that general handout 5, which is the next handout, which I don't have a slide for here, is what addresses the biosocial theory that we discussed earlier. And this handout can be really helpful to use with patients one-on-one as you're orienting them to group, as you're determining their appropriateness for DBT, those types of things. It is not a necessary handout to use. So we're going to do some questions, and then we're going to have a little extra time for mindfulness, possibly. The first question that I've got here is, what are your thoughts on utilizing DBT-informed treatment for group sessions with children ages 5 to 12? That is a great question. And I don't know if I'm the most qualified to answer that, because while I have worked in day treatment settings with middle schoolers, my experience with that was not nearly as intensive and extensive as my experience with adults. And I can tell you that I have seen DBT skills be used in group settings with children and adolescents as a supplement, but in a very structured way. And there are very specific handouts and worksheets that you're going to want to use that are much more targeted to those populations. Because the adult handouts use a lot of big words and have no pictures and are not fun for kids to look at. So I'm going to encourage you to take more of a targeted look at some of the information out there. I know there was also, I'm thinking by now it's been published, but I haven't actually seen it yet, a DBT manual for working specifically with children, I believe ages 7 to 12. Because there is a really different skill set that's needed there. And honestly, another big difference between working with children or adolescents and adults is that best practice for children and adolescents in DBT is to involve parents or caregivers in the skills training so that they can support use of those skills at home. So best practice for those groups is going to be more like a multifamily group where one or more family members come in with each of the kids to the group and they're all learning the skills together, rather than just teaching to the kids. That said, I have a feeling that at least teaching to the kids is going to do more good than teaching nothing to them, if that makes sense. I hope that that was helpful. Next question that I've got is, please share an example of problematic venting versus appropriate sharing. We often struggle with this concept in our group work. Great question. So examples I give here are problematic venting in my mind would be, oh my gosh, I had the worst week. It was horrible. You guys have to hear this. You're never going to believe what happened. But I don't want to hear about what skills I need to use. And you know what? I'm just doing the best that I can. And I don't want to hear about the skills. I just have to get this out. That's venting. That's letting stuff out without any willingness to receive feedback or coaching on how to address those situations using the skills, which is the focus of the group. So appropriate sharing in that regard might be during the homework portion of group, which I know we didn't get to that slide and I'm sorry. We start group with a mindfulness activity. We then orient them to what our agenda is for the day and any housekeeping stuff. And then we do homework review. And then we introduce new material and then we assign homework for the next week. So first homework review is a really good time to address those types of things. Framing it as I'll give you two examples. One is, I had this situation come up this week and I want to tell you guys what happened, and I'd like to get some ideas about how I could do this differently in a way that would feel better for me, or if you have any thoughts on how that I could be more effective here. Or, you know, what skills might apply, because I don't even know what skills to use in this situation. So here's what happened. That is completely appropriate and actually really important as a part of skills training. It can also be important as you're teaching new skills. and people are like absorbing what you're teaching and what the skills are and how to apply them, for them to say, I had this situation come up this week. Would this have been an appropriate time for me to use that skill? Ding, ding, ding. Appropriate use of sharing. I hope that that answers that question as well. I've also got, how do you address people who won't turn their camera on in Zoom or remote sessions? We're asking people to turn cameras on, as many clients feel upset when they have their camera on and others do not. I'm probably not the best person to ask about this because I am not currently running any groups over video. I'm not currently running any groups, period, right now. The only skills training that I have personally done during the pandemic has been individual. That said, I have seen guidelines in some of the behavioral tech newsletters around how to shape patient behavior in regards to Zoom sessions. And there is a recommendation around orientation of the patient to what is expected during group, what's okay and what's not okay in regards to who's in the room, having a confidential location, and active participation in group, what that looks like. They did a lot of orientation, which I thought was interesting, around how to place your camera so you're not staring at someone's chin because they're holding the camera up from their phone on their chest, and making sure that they have decent lighting. Which I'm struggling with. I'm not dressed anymore. Recognizing and framing that this is a public interaction, in the sense of the group is exposure to other people. And if you wouldn't walk into group with a bag over your head, our expectation is that you come into group with your camera on. I think it's up to you as a skills trainer what your personal limits are and what the patient's needs are, in not just that patient, but the needs of the group as a whole, in regards to how directly you're going to address that and how much of group you're going to take up with begging the person to turn the camera on. One of the slides I'm going to be going over in the next training has to do with targets in DBT skills training. And our first target is always therapy destroying behaviors. So if it's something that has the potential to make someone drop out of group, or to make them not able to ever attend group again, that's going to be a priority to address right then in group. Our second priority is always going to be teaching the skills. And our third priority, which very infrequently gets addressed directly while group is going on, is therapy interfering behaviors that may, most of the time, are just going to be ignored, but otherwise are going to be addressed on the sly by the co-facilitator if possible, and are going to be discussed more extensively in individual therapy or one-on-one before or after group. I hope that's helpful. Next question, what were the authors for the DBT skills training book for adolescents? I know you mentioned it, but wanted to jot it down. I do not have access to my slides right now. Erin, I don't know if you can toggle back right now in the slides to, I think I've got one earlier on doing DBT with adolescents that might give the specific name of that book. Or did I not put that in? Maybe I didn't put it in. Yeah, I believe it's Rathis and Miller. I can look that up for you guys at lunch, actually, and I'll make sure to get you that specific information and the exact title of the book after the lunch break. Next question, do you think handout 5 has potential to make excuses for abusers and reinforce self-blame of survivors? I think it absolutely depends. And I think the answer is it could if the context is not framed in a way that's helpful to them. I can tell you that the way that that handout presents it, honestly, is not a way that I typically present it. I typically discuss it in a much briefer fashion, describing it as an interaction between a biological predisposition and an invalidating environment. I can also tell you that my understanding is that the reason that Marsha Lenehan has framed this handout the way she has is because there is also the potential to blame the environment because of the fact that it's invalidating without taking into consideration the context of how or why that invalidation happened. And in a way that can increase distance between patient and environment rather than increasing connectivity and willingness to work together. I will say that in active abusive situations, our number one priority is always safety. Always, always, always. And we are not looking typically to get abused patients to have more effective communication with their abusers. We're looking to get them to a safe situation and to minimize the potential for abuse. So we're not gonna focus on those reasons for invalidation or potential reasons as much as we would with someone who's not in an actively abusive situation. I hope that that answers that question as well. If you have additional questions or feedback around that, please feel free to add into the Q&A. And without further ado, I am going to move on to our mindfulness module. So we're looking now at mindfulness handouts 1 through 5C, if you can bring those up in your books or your printouts or your electronic copies. Also want to reference, I think most of you got an email to this effect or have received some communication around this. If you purchased the DBT Skills training manual, at the beginning of the manual, on page XI, how to use this book, there is a link where you can find electronic copies of all of the handouts and worksheets for no additional cost if you have purchased the manual. And it can be really helpful to print out handouts from online rather than trying to copy them even out of your spiral bind book, which I got to tell you from experience is a lot easier than copying out of a regularly bound book, which I did for years, which is why my books are a mess. But you can get some nice clean copies from there and it makes life a lot easier. So next slide, Erin, please. Our first handout is, and I've got to get to the right handout myself here, goals of mindfulness practice. So this handout is basically a quick orientation and review with participants of what we're looking to do with mindfulness. We want to identify that reducing suffering and increasing happiness as a goal, which sounds like a lofty kind of pie in the sky goal, can occur through learning to experience things as they are without adding additional painful thoughts to already hard circumstances, or missing out on details of something that has the potential to be really pleasant that we might not be present with otherwise. It is not about like creating rainbows and unicorns and having a happy, fluffy cotton candy kind of world, because that's not reality. It's about cutting down on the excess fat of our brains in terms of unnecessary thoughts that lead to pain and suffering, and difficulties with focus that can lead to missing out on potentially pleasurable events. There is some evidence from research about mindfulness listed on page 162 of your skills training manual that can be really helpful to introduce with patients here, to give them a little bit of a carrot to dangle in terms of things that mindfulness can do for us when we practice it consistently and in a way that's helpful. So, you know, that can be great to use for your groups or even for your individual sessions. When we talk about getting control of our minds, getting control of our minds is not about drinking the Kool-Aid and saying, oh, mindfulness, it's the greatest thing ever. No, we're not looking to make people drink Kool-Aid here. We are looking to help people make more conscious choice. We our minds jumping around all over the place and easily being distracted by things and thoughts, and increase our ability to focus on the things that we want to focus on. Connectedness to the environment around you is important. And that's in regards to experiencing reality as it is. It says connection to the universe, which I typically get a lot of feedback like, oh boy, here we go, connection to the universe. Ooh. The idea here is recognizing that we don't live in a bubble. It's not about like, we have to be connected to the stars and, you know, all the planets will, no, that's not. It can be about that if you want it to be about that, but that's not what this is intended to mean. The intention here in my interpretation and the way that I teach this is that it's the recognition that we live in an environment. There are things around us that we are connected to, like it or not, and being able to experience what that reality of being connected and being a part of our environments is like, especially during times when we're isolated, like during COVID, is really important to feeling okay and to recognizing that our actions have consequences for more than just ourselves. The idea of essential goodness can sometimes be really hard, especially for people who have trauma histories, people who have really poor self-esteem or low self-confidence. And recognizing that that's a goal is important. Recognizing that no one has all good or all bad qualities is important, and that we all have qualities that can be helpful, lovable, and likable in spite of other qualities we have that might be a challenge to ourselves or to others. Going back to our question earlier about people who might have experienced abusive situations, important to frame this as we're not digging for how you can love your abuser. That's not what this is about. This is about learning to be present with and love the things about yourself that are lovable and likable. The essential validity piece is the concept of being a living being who has thoughts, emotions, and behaviors that make sense and are valid given your history and your current circumstances. So we might have the same experience and you might feel completely different about that experience than I do. And both of our feelings about that are valid. Different people are going to feel different ways in regards to the same circumstances based on their own needs, their own experiences, and their own histories. And we all are valid in terms of what our input is, in terms of what our needs are. We're going to move on to the next slide. Mindfulness definitions. This is intended in the curriculum as a handout for participants to take home and review. That is the coaching around teaching this. I have personally found this really helpful to teach in class or one-on-one, however you're teaching, if time allows. Because my experience has been not everybody does their homework. So if this is something you think is important for people to know, be redundant, go over it with them. It is mostly a straightforward review. And by the way, when I teach this material, a lot of times if I'm in a group setting, we'll go around the group and I'll have each person read a bullet point. So we're not all just sitting there listening to me drone on like you people are having to do today. I apologize. It's hard for me to not have the interaction, and I'm going to get through it. So going around and having each person read can be really helpful. One-on-one, you can go back and forth with reading. You can ask them to read it out loud, or you can just read it, whatever makes sense. This can be a really helpful time to introduce patients to the concept that the act of mindfulness engages the prefrontal cortex, which is a part of our brains that can act as a mediator to facilitate balanced communication between the emotional and the rational parts of our brains that otherwise kind of butt heads and yell at each other. So our prefrontal cortex is a part of our brain involved in just noticing on purpose in the moment what we're feeling, what we're experiencing, and what's going on around us, what our five senses are picking up on. And that sounds an awful lot like mindfulness, right? So the practice of mindfulness actually can help to strengthen those connections in the prefrontal cortex, kind of like a bodybuilder lifting weights. They're not just going to lift weights one time and expect that they're going to have a great body. Something they have to do every day. And it's something that takes practice and repetition in order to get things where you want them to be. And the more stressful a situation is, the more practice we need to have ahead of time in order to be able to access that part of our brains. This is also a helpful time to introduce the concept, because some patients pick up on this like gangbusters if they've got any difficulties dealing with spirituality or organized religion. The idea that mindfulness is a practice that was developed out of Eastern spiritual practice, but it is not necessarily religious in nature, and that it can be found in the spiritual practices of many religions across the world, both Eastern and Western. And it does not require any religion or spirituality in order to use it effectively and have it be helpful to you in being able to be more present in your own life and being able to get a solid foundation for grounding your emotions. It is really important to be, that said, to be respectful of participants' individual religious and spiritual beliefs and practices, and to reassure them that mindfulness skills in DBT are intended to strengthen their skills, not to influence their religious perspective. Can also say from personal experience, if you end up with a group where you have some people who are extremely religious and other people who are extremely and vociferously not religious, things can get really interesting. So I encourage you to be aware of your mix in the group and to ask that people bring conversations to individual therapy if things start to get too out of hand, and refocus it back to the skills that we're working on. Next slide, please. So the core mindfulness skills, our overview, and I'm just taking a second to look back at my timing because we're going to be breaking for lunch at 12:10. We're doing great. All right, we got plenty of time. And if we end up with extra time at the end, I may go back to some of the earlier handouts that we missed and fill in some of that time if that's okay with people. So mindfulness handout 2 is an overview of the core mindfulness skills. This is a brief orientation to participants that the skills of wise mind, the what's in. Not only is this a foundation for other skills, but it's almost like these are the bricks that we're going to use to build our house. And without these bricks, we can't build a house by using other skills very effectively, or it's going to fall down. So I also like to introduce at this point that we've got some funny words, and this is where DBT is going to start getting into some acronyms and some really funny words, and that's a DBT thing. And it can be helpful to our prefrontal cortex to be able to have labels for things, many of which we already do without noticing it, so that we can call up those skills during times when we need them in an accurate and effective way, rather than just shooting in the dark. And to also describe that the what skills are called the what skills because they are what we do when we're practicing mindfulness. So when we're practicing mindfulness, we're observing, describing, and participating. Those are the what skills. The how skills are how we practice the what skills. So our how skills, non-judgmentally, one mindfully and effectively, are how we're going to observe, how we're going to describe, and how we're going to participate. We'll get more into this as we do a deep dive with these skills. Super important point with mindfulness. Orienting yourself, reminding yourself, and orienting participants that mindfulness is about being present with what is. And what is may not always be a pleasant thing. There are patients who experience trauma, who experience, really difficult things in their lives, who develop fantastic skills for cutting things off and avoiding and numbing things in order to cope. And when that is the case, mindfulness can feel incredibly threatening because mindfulness is asking them to do the opposite of what has been effective for them for so long. The problem with numbing and avoiding and just not being present with things is we can only do it for so long. We only have so much capacity for it. And at some point, we start reaching a breaking point. And I always tell people it's like when you take a bottle of soda and you shake it up and you put it back in the cupboard. And you take it out and you shake it up and you put it back in the cupboard. At some point, that bottle of soda is going to explode all over the place and make a giant mess. Mindfulness in short bursts, this is where I encourage what I call an approach and retreat strategy. So we're not asking someone to sit with their difficult feelings and thoughts for an hour. We're asking for short bursts. What can you tolerate right now? Is 30 seconds something you can tolerate? Great. Let's try that. We'll start from there. Can you tolerate 3 minutes? Fantastic. We're starting small and we're practicing in very short bursts. I hope that kind of makes sense and is something that you guys can keep in mind moving forward and addressing some of the resistance that you are likely to get from a lot of your patients when you bring up mindfulness or when they start to practice it, because sometimes it isn't pleasant. And when people get the idea that mindfulness is supposed to make them feel good and supposed to, be this great, wonderful experience, which it can be, it isn't always. And that's important for them to know. And it doesn't mean that it's not still important as a foundational skill for being able to move forward. That said, cultivating experiences in mindfulness when people are new to it that are as pleasant as possible for them can help to increase their motivation for practice. As they get better at it and as they develop more tolerance, you can start to integrate more challenging experiences. And this is where I get groans in groups sometimes, because I've done mindfulness exercises with people before. Please don't start with this, please, please, please. This is once you know your people really well and you got a great relationship to lean on, because they're going to hate you for this. But you walk in and you say, okay, we're doing a mindful coloring activity today, and you don't get to pick your colors. I'm going to reach in the box and you're going to get what you get. And I want you to be mindful with the thoughts and emotions you have about the 2 colors that you ended up with. And some people hate that activity, hate it. And learning to be present with negative emotions is just as important as learning to be present with positive emotions. And please don't start with that. Let's see. Processing after mindfulness activities. I think there was a question that had popped up in the chat earlier that never showed up in the Q&A. And I want to encourage people, if you have questions, put them into the Q&A because we're only looking at that for the question and answer sections. But I think there was a question at some point that popped up around how to process or what you do to process the mindfulness activity. In a group setting, I allot more time to process mindfulness than to do mindfulness. My mindfulness activities are very rarely longer than 3 to 5 minutes long. The processing is going to be 5 to 10 minutes long if you're in a group, because you want to give multiple people a chance to respond and hear different points of view and encourage different points of view. But what I like to ask people for processing is, how was that activity for you? Or what did you think of that activity? Or what was your experience with that activity? And just invite feedback. And if you are hearing feedback that like, oh, I wasn't doing it right, or, I can't do mindfulness because I get distracted too much, or I didn't do it at all, you can have the opportunity to coach them through and correct any misperceptions. Like there is no perfect in mindfulness. if you are noticing when you're becoming distracted by thoughts or by things in your environment, and you are redirecting your thoughts back toward where you want them again and again and again, you're being mindful and you're doing exactly what mindfulness is designed to do. Because every time you notice that you're being distracted and you redirect those thoughts gently and skillfully back toward where you want them to be, you're doing one repetition, one weightlifting repetition in your prefrontal cortex. And every time you do that, it's going to get stronger. And over time, you're going to notice that you can focus for longer, and that the time in between distractions gets shorter and shorter and shorter. So let's see. Important idea here that engaging in your own mindfulness practice as a clinician is essential to teaching these skills effectively to patients. And I will say that for mindfulness. I will say that for every single one of the skills in DBT, honestly. I tell my patients all the time, I don't teach these because I think they'd be helpful to you. I teach these because I use these every day and I know they're helpful. And I know that not all of them are going to help all the time. And I am confident that if we work together, I can help you find skills that are going to be most helpful for you. And here's what my experience has been. You tell me if that's what your experience is or if yours is different. And if you're not practicing mindfulness, or any of the other skills, you're systemic without my DBT skills. So, and through a lot of other hardships as well. I teach them, I get passionate about them because I've seen them be so amazingly life-changing for people and because they've been life-changing for me. Next slide, please. Can you move on to the next slide, Erin? Awesome, thank you. So this is not in your books, this is not in your handouts. This is something I'm guessing most of you are going to very readily recognize. This is the CBT triangle. This is the foundation of everything that we're going to talk about. This is why what I call the DBT Bible, I'm looking at it over here, is called the Cognitive Behavioral Treatment for Borderline Personality Disorder. It is based in CBT. And this triangle is going to represent the 3 factors that are present in every experience that we have. And I like to draw this picture. Actually, you can't see it right now. If you want to see my board, I'm happy to turn my monitor around later on. But I've got a whiteboard that every office that I've had that has had a whiteboard has had this drawn on it. And I draw it at every group because I reference it a lot. And I feel that it's important to orient patients to in order to have a foundation to understand what we're talking about in regards to some of these skills. So I explain this to people that the triangle is going to represent the 3 things that are present for us in every single experience that we have. So we call it a triangle because each of these 3 factors is interdependent on each of the other factors. A change in one leads to changes in the other 2, and vice versa. So our feelings, which I couldn't find one that says feelings, it says behavior with the British spelling. I was a little annoyed by that, and I'm rolling with it because I didn't have time to make my own drawing on my computer. I apologize. So feelings, which are going to include both our emotions, and our physical sensations are the part of the triangle that is the least directly under our control. We can control our awareness of our feelings, and we can absolutely control what we do with our thoughts and our behaviors in order to influence our feelings. But we can't just will ourselves to feel differently than we feel. In terms of thoughts, whether our thoughts appear in our minds is not under our control. They just show up sometimes without an invitation. But our awareness of our thoughts and what we choose to do about them once we're aware of them is. So keep in mind that steering our thoughts can be kind of like steering a ship. We're not going to do a 180 and change them immediately. It takes time. And it takes repetition, and it is possible. In terms of behaviors, I like to describe behaviors to people as anything that a video camera would be able to see you do, which is sort of funny as I'm talking to a video camera right now. It's a little weird. So this is going to be body language, like I'm talking with my hands a lot. Facial expression, noises that we make, movements that we have. These are all behaviors. Action urges are the urge that we have to do a behavior before the behavior happens. So I like the saying, it's what happens before what happens happens. And the more that we can develop awareness of those action urges, the compulsion to do something before we actually act on it, the more we have a choice about whether to engage in those behaviors or not. That said, if we are not aware of our action urges, it can be really challenging, if not impossible, to be making mindful choices about our behaviors. So in the short term, especially when we're being mindful, the interesting part here is that we have the ability to take that triangle, which is all connected, and disconnect the behavior and thought part of the triangle from the emotion part of the triangle. To say, I know I'm feeling this way, and I think that it would be more effective for me to behave like this than how my emotions want me to behave. So in the short term, we can absolutely engage in thoughts and behaviors that don't line up with our emotions. And that takes a lot of attention and a lot of energy. In the long term, it tends to be really difficult to maintain that focus that can help us to separate that triangle in a way that over time will hopefully drag the emotions closer to where we want them to be. In the long term, if there's not immediate payoff with those emotions, what happens is we lose focus on the behaviors, the action urges, the thoughts, and they start lining back up with the emotions. Well, I really want that piece of cake, so I'm just going to eat it. Well, I'm really angry at him, so I'm just going to lash out because I don't care right now. And whoops, that was not what I thought was going to be effective. Which is why it's really common for people to start diets and stop them very soon thereafter, because it takes a lot of energy and intention to do things differently. All right, next slide, please. Wise mind, the first of the foundational skills of mindfulness, states of mind. So and this is handout 3, by the way. In a very simplified way, our brains have 2 major functions, which is to be rational and reasonable, and to weigh the consequences. And would you be able to go back one slide, Erin? Whoop. No, back to the wise mind. There we go. Thank you. So rational or reasonable mind is the part of our mind that it makes sense of things, and it likes to make sense of things. And for those of us who really like to think about things and really like to figure things out and really like to understand things, that's all rational. And it can be very rewarding. Like, we can get a dopamine hit from that, right? Like, it makes sense. We love it when that happens. That's the rational part of our minds. The emotional part of our minds is the part of our minds that says, that felt horrible, I am so never doing that again. Or, oh my gosh, that's amazing, I have to do that again. It's the part of our minds that gives us really important feedback about what our personal experience is. So if you think about it in terms of that CBT triangle, the rational part of the brain is going to go straight from thought to behavior, and it's going to bypass the emotional part. And the emotional part of our brains, emotion mind, is going to go straight from emotions to behaviors. Maybe it'd be more like that. And emotions to behaviors, and bypass the thought piece. The hard part is that, for a variety of reasons that I'm not going to get into today, because we just like those parts of our really nice together. It happens sometimes, and a lot of the time they're very separate. The rational part of our brain is going to tell us, this makes sense, this is what I should and shouldn't do, this is what looks great on paper. And the emotional part of our brain is going to tell us, this thing looks a little bit like this super traumatic experience that I had 3 years ago. So I'm going to avoid this with all costs, whether I'm even realizing that I'm avoiding it or not. It's going to go straight from the emotional part of our brain, or even our amygdalas, directly to our bodies, and kind of bypass that rational part, even though the rational part might be yelling at it. What are you doing? Why are you doing this? Nope, emotional part is driving the bus. So wise mind is the experience of being able to be present with both the rational and the emotional parts of our brains at the same time. Finding balance in both as we find a way to move forward. When we talk about wise mind and using our wise mind, we talk about language like both and we call this in DBT both and thinking, rather than either or thinking. So I am both being mindful of what makes sense and being mindful of how I feel about this situation. Okay. So the metaphor of taking the blinders off is the idea, sorry, this is a horse metaphor. I'm a horse person. You may see various horse pictures in the background. Carriage horses wear blinders, so they can't see anything except for what's in front of them, lest they realize there's a carriage behind me. Oh my gosh, I'm a prey animal. It's going to get me. I need to run away. So they wear these things on their faces called blinders that keep their vision tunnel straight ahead. And when we are in rational mind, we have blinders on for what makes sense and what looks good on paper. And likewise, when we are in emotional mind, we have blinders on for what feels good or what doesn't feel good, or, you know, what reminds me of this traumatic experience. Wise mind is the idea of taking those blinders off and allowing yourself to see all of it. Not just this part or just that part, but all of the parts. And to find a way forward that considers all of the parts rather than just working a little bit here and then jumping way over there because our emotion mind says, don't do that. And then our rational mind says, emotion mind, you're being crazy. Let's go back over here. We're going to look at the whole picture and we're going to find a way forward that considers everything. Next slide, please. All right, I'm moving my little video screen around so I can actually see my notes here, and we'll bear with it. So ideas for practicing wise mind. This is handout 3A. There's a lot of different ideas here. I think it's a 2-page handout. It is. And it's going to give a lot of different ideas for like guided visualization, for actual practice that can sometimes be helpful with practicing wise mind and getting into wise mind. Big blinking red disclaimer, not every idea is going to work well for everyone. Some of these scripts can be really disturbing to people. There's one in particular about walking down the spiral stairs, number 2. And some people say, oh my gosh, I hated that. I got trapped on the stairs. They never ended, or my stairs ended and I dropped off into oblivion. I don't ever want to do that again. Be aware of this. I personally am not a fan of stone flake on the lake because that sounds a little too much like drowning to me. That's stone flake. Like, how do you breathe? I recognize stone flakes don't need to breathe and my brain just can't go there. So different exercises are going to work best for different people. Almost all, if not all of these, are available for free in narrated form on YouTube if you do a search, which is super cool. So I encourage you to encourage your patients to check those out. If you check them out and find some that are really good, you can use them in groups or sessions. You can orient your patients to them. A lot of them just have one picture and someone narrating or guiding the meditation. I highly recommend that you practice each skill set before you ask your patients to try them so that you have a better idea of how to troubleshoot things with them and you understand what they're talking about when they're referencing things that are being difficult. That said, also encourage your patients to practice all of the skills and try all of the skills at least 2 to 3 times, unless they have a super duper traumatic reaction to one that's just like, our goal is to make things better and this is making it way worse. By all means, you tried it once, move on. But otherwise, if it's something that you're just like, this is dumb, which is a response I get a lot from people, because some of them feel silly and awkward. Encourage them to try them at least 2 to 3 times before they totally write them off as not helpful, because sometimes continued practice can build tolerance and help them to see more than just what's weird and different. Validate that these are awkward to yourself and to your patients, and remind them of the connection to achieving their own life worth living goals. In order to get to be able to go to college or to start your own business or to do whatever it is that you want to do, have a great, fantastic relationship. It is really, really important to be able to access both your rational and emotional mind and make decisions you can feel good about. And that's why I'm asking you to try these things. I know it's weird, and we're going to do it together. Make sure to orient your patients that it is super normal to become distracted and how to redirect their thoughts, which is calmly, kindly, and gently, not, oh, you idiot, you're getting distracted again. Or, see, I told you you can't do that. Because those are the scripts that go on in our heads, right? We all have those scripts that go on. And the more we can redirect those thoughts toward, there's a distraction. Where do I want to be focusing right now? The less aversive this type of practice can be. Remind yourself and your patients as well that learning new skills, any new skills, are going to be best learned under low stress circumstances and then built on so that we can access them under higher stress circumstances. If someone's looking to run a marathon and they've never run before, we're not going to expect that they're going to maybe even survive running a marathon if they try and do that without practicing and practicing and practicing every day and building up. There's that Couch to 5K program that does exactly that, right? It doesn't take you to the marathon level, but it builds and builds and builds over time. That's what mindfulness needs to do. Because you can practice mindfulness one time in a session does not mean that under the gun in a super high stress situation, you're going to be able to make a super wise-minded decision. And it doesn't mean that you can't get there over time. Please ask your patients for feedback on what their experiences are like. Don't just teach the skills and move on, because having issues that you're taking a few minutes to problem solve what they're going through can really go a long way. All right, next slide, please. I'm going to do my best to move quickly through these because we got about 8 minutes before we start taking questions, and we got a lot to cover. So bear with me. The what skills, handout 4. Observe, describe, and participate. These are what you are doing when you are practicing mindfulness. Observe is the foundational what skill because it is absolutely necessary in order to practice just about any other skill. If we are not observing what's happening, we don't know what's happening. We're not being present with it. Make sure that you focus on this skill in particular to the point of clear understanding and get feedback to make sure that people understand this. In the third bullet in the observe skill, control your attention but not what you see. Push away nothing and cling to nothing. That says a lot in one spot and it's a little confusing. I encourage you to use examples from your immediate environment. So what I was kind of known for when I was doing my last DBT group was I did it in a group room where one of the walls was orange, and where I sat, the wall directly across from me was the orange wall. And I would say I recognize that there is a wall painted orange in front of me. If I don't like the color orange, which is not my favorite color, it's not horrible, but it's not my favorite, I'm not going to deny that there's an orange wall in front of me. But I am going to recognize that if I'm not fond of the color orange, or if it's bugging me that day, I can move my chair or I can look in another direction if I don't want to look at the orange paint. So I can control my attention, but I can't will something to not be there if it's there. In the cling to nothing portion of this, it's important to identify that holding on to past positive experiences doesn't allow room for new experiences to come your way. So I might have the thought that like, I got pretty good at teaching DBT in front of an orange wall for 5 years. What the heck am I going to do if I don't have an orange wall to use as an example? But when I cling to nothing, I can recognize that I have got plenty of examples in my current office that I can use as I'm teaching skills. And some of them might be even more effective than the orange wall was. For the wordless watching point, I like to encourage patients to think of other metaphors in addition to the clouds in the sky metaphor to describe the nature of their thoughts. So race cars on a racetrack, billboards on a highway. I had one person describe like ping pong balls just bouncing all over a room. Encourage them to make up their own metaphors. And that's actually a mindfulness I like to do as well, is just to encourage people to think about what their thoughts are behaving like that day and what metaphor they would use to describe it. I'd like to take a few minutes to discuss the wave of emotions example at this point, because I've had a number of people give me feedback that just being able to get this one piece of information has been a pretty life-changing experience for them in terms of regulating their emotion and being able to tolerate it. So next slide, Erin, if you're okay. Awesome. So I did make this fun little chart. I had time for this one. This is a representation of the wave of emotions. We start with a prompting event at the left-hand side. This is something that either happens around us or a thought in our heads that prompts an emotion to begin. The emotion is then going to build to the climax, which is the highest point that that emotion is going to get to. And then if it is not prompted again by another thought or another experience, and that's important to be aware of, it is going to subside and go through the emotional half-life, half-life being a chemical term for the amount of time it takes for any chemical to break down in the environment by at least 50%. Our emotions being chemical reactions in our bodies. And once our emotional related chemicals or hormones break down by 50%, that emotion no longer has the power over us or the intensity that it once did. The after effects being what I like to describe as the emotional hangover. So they're what you feel as that emotion subsides. It is not a new emotion. It's like when we've been really sad and then we just feel exhausted, or we've been really angry and then we're just irritable. It is not a new emotion. It's just the after effects. So I like to ask for feedback from people on how long they think it would take to get from a prompting event through the build and the climax down to the half-life for one emotion. And typical responses are anywhere from 2 minutes to 5 days. There's a whole range. Reality is that if there is one prompting event, with very little exception, the time from prompting event through emotional climax to half-life is 90 seconds. So what happens when we experience emotion for longer than 90 seconds? We have a prompting event, we get a phone call from someone, and then we have a thought, I can't believe they just said that. And then we have another wave of emotion. And then we have another thought, now I'm gonna have to do this. And we have another wave of emotion. And pretty soon we're surfing on top of that climax. And it's never having a chance for us to experience that emotion subsiding. I'm going to move on to the next slide. I'm a little torn because I'm realizing that I need to be starting with questions, and I've not gotten very far through the mindfulness skills. I'm going to go through this skill and then take questions if we have time, I will, actually, I'm just going to do a couple questions probably. And then I'll wrap up the remainder of the time before lunch with skills. And then whatever we didn't get to, I will start up with after lunch. So the what skills? Describe. This is putting a label on things that you notice, using your inner narrator to tell yourself about what you're experiencing. So thoughts labeled as thoughts, feelings labeled as feelings, and factual descriptions of what you notice with each of your 5 senses are all objective observations that fall under the describe skill. Also, another great litmus test for are you using objective observations in observe and describe is, would 100 other people all looking at the same thing all hear your description and say, yep, I see that too? Or would they hear it and say, you know what, I see it differently? Also, would someone who's not in the same room with you hear your description and get a fairly accurate idea of what you're paying attention to? Or would they get a totally different idea of what you're trying to describe? Important to recognize that describing a feeling as just a feeling and a thought as just a thought does not diminish the importance of feelings and thoughts. They can at times be intolerable and they can be very important to our experience. But putting them in perspective is important. Thoughts and feelings can't be seen, behaviors can. Thoughts and feelings can be really painful and they cannot cause physical harm and they can't kill you. Behaviors can. The next slide, please, Erin. Describe, no, other direction. Yes, participate, thank you. So participate involves doing whatever you are doing with all parts of yourself, your thoughts, feelings, and behaviors without self-consciousness. Examples of participate are getting so engrossed in a book, a conversation, a movie that hours have gone by with an eye. The intuition, rapidly. It's holding your own space. I always think back to the Dirty Dancing movie here, where Patrick Swayze is teaching baby how to dance, and he's saying, this is your space and this is my space. You do what you do, I do what I do. It's holding your own space and your own role in the events of your life and not taking on everybody else's stuff and not expecting them to carry you through it either. Spontaneous actions are done in the moment without planning and with awareness of our rational and emotional reactions. Spontaneity involves the use of wise mind. Impulsive actions imply lack of self-control and the ability to stop what one is doing, typically resulting in feelings of regret. So if we're acting impulsively, we feel like we can't stop and we might feel bad about it afterward. Can we go to the next slide, Erin? I just want to see where we're at. Okay, I'm not going to get in detail here. I'm going to encourage you guys to look at the A, B, and C for Mindfulness 4, ideas for practicing observe, describe, and participate. There's some great additional ideas in the manual. And I want to encourage you to look them through and find things that you think would be helpful to use with your patients and to reference with your patients. Next slide. I just want to see where we're leaving off before questions. Okay, so we are going to get to the how skills after lunch break. I'd like to leave a little bit of time for questions. And I'm just going to make a note of where we're at. All right, so our questions are, I can get my mouse to work. Many clients I work with struggle with mindfulness because they hold the idea that they have to completely clear their minds. Oh, I love this question. How do we help clients to recognize that the goal is not to have a completely empty mind, but to be present in the moment? So this is a great question. Mindfulness is not about clearing your mind or stopping your thoughts. Mindfulness is about acknowledging and being present with each of those points on the triangle, our thoughts, our feelings, our behaviors, and acknowledging what's there. Not changing it, not stopping it, but just observing, describing, and participating with it, non-judgmentally, one mindfully and effectively. Next question, I find that if I actually practice what I preach, it helps my clients. Amen, absolutely. I appreciate that comment because I totally agree. And next question is very related to that. I can speak from experience and not just know from a book or a class, which is so important to the radical genuineness that we talk about needing to have when we practice DBT. It's not about what we do to our patients, it's what we do with our patients. And it's about sharing things that we find helpful. Can you link when discussing with clients worksheet 3, can we bring in psychoanalysis, part of the id, ego, superego, and help explain this to clients to help their understanding as a possible analogy? And this then sounds like it links to defense mechanisms that then occur emotionally and behaviorally. I think if that's something that fits with your current practice and that's something that makes sense to you, I would encourage you to use whatever examples make sense. Because I think there are absolutely parallels there. I would encourage you to make sure to not just label the emotion mind as defense mechanisms, because emotion mind is more than that. It absolutely is defense mechanisms, and it's important information about our environments and what our experience is. Things that could be helpful or harmful, things that match with our values or don't match with our values and goals, things that are important to us. So absolutely, if there are parallels that you're drawing as a clinician between what you're learning about the DBT skills and things that you are already doing in therapy, that's a great opportunity to build on what you're already doing and enrich that experience. All right, wow, we went through questions super fast. I have about 3 minutes before lunch. If you guys are okay with that, I am going to at least start the house skills, which may be a tall order because non-judgmentally is probably one of the most frequently challenged of the mindfulness skills, but I'm going to do my best. So, non-judgmentally is typically the most difficult skill to teach. It is the most often challenged skill by participants. And it is a skill best learned through practice, feedback, and coaching, rather than just understanding rationally different concepts behind things. Please remember that non-judgmentally does not mean that we condone or endorse how things are, only that we acknowledge them as facts. And the language around this in the handouts can be very confusing. So I really encourage you to clarify this for the people that you're working with. Judging something as good or bad tends to file that thing away in a category in our brains that can be hard to escape from if circumstances or behaviors change at some point in the future. So being able to discern things that are helpful or harmful, safe or dangerous in the moment, but trying to stay away from descriptions of good or bad is really important here. So an example here that my good friend Heather Hubany gave me, I'm gonna give her a shout out for this one because this was really helpful to me, is if I take the milk out of the fridge in the morning and I drink it and it's curdled and it tastes terrible, I might describe that as the milk is bad. And it's very common for us to say, oh, the milk is bad. Now, just because that curdled milk gave me a stomach ache doesn't necessarily mean that all milk is bad. And if that was the first experience I had with milk and I'd never drank milk before, I might think that like milk is bad. I don't want milk if that's what milk is like. But this is recognizing that in that moment, I'm going to describe non-judgmentally that that milk is curdled, that milk is past its due date, it's sour. And I'm going to stay away from saying the milk is bad. Because if I go get more milk, it might taste fine. Should can be a huge red flag that judgments are happening rather than an acceptance of the facts as they are. So I like to say to people, you shouldn't should yourself. And I really like to try and catch myself as much as possible when I use the word should, because it implies judgment. And digging deeper to the intention underneath the should is important. So we can observe our values, our emotions, our wishes, and our thoughts by making objective observations rather than shoulding ourselves, or deciding that our experiences are inherently good or bad. It's all about the perspective that we look at it from. So I think I said earlier, I should be teaching this in a certain way, or, you should present this. And then I backed up and said, what's recommended is, and this is why. And that's a much more non-judgmental approach to description. We practice non-judgmental stance because judgments have a strong impact on our emotions. Guilt, fear, and shame frequently come hand in hand with judgment. And judgments absolutely can impact and damage relationships. Judgments are also rarely effective in changing behavior. You can copy problem based on those changing behavior than judging and blaming. When we notice judgments happening, we want to acknowledge the judgments and kindly and gently turn our attention toward objective observations of the facts, our emotions, or potential consequences. Again and again and again, because we all judge all the time. We're human beings. It happens every day. And catching ourselves is a part of that journey. So that said, I also wanted to revisit from earlier, there was a question about the Adolescent Skills Manual. The name of that manual is the DBT Skills Manual for Adolescents, and that is by Jill Rathis and Alec Miller. And that is considered a best practice for use of DBT with adolescents. Want to also give you guys a heads up, because I forgot before the lunch break, because I was in such a frenzy to try and finish the mindfulness skills, that if you can grab a clean piece of paper for a mindfulness activity that we're going to be doing, and I'm going to take one out right now myself. Once we finished these next 2 or 3 slides, we are going to move to the afternoon portion, which was intended to start with a mindfulness activity. So if you can have a clean piece of paper and some sort of writing utensil, pen, pencil, crayon, you name it, that's what we're looking for our mindfulness. All right, taking hold of your mind, the house skills, we are talking about one mindfully now. We finished up with non-judgmentally last time. We live in a world, a society that values and reinforces and rewards multitasking. And The reality is that our brains are only capable of effectively focusing on one thing at a time. So what happens when we multitask then? Because some of us can be very effective at multitasking, right? We get really good at it. So what actually happens when we multitask is our brains jump between areas of focus and fill in what they think happened while they were paying attention to something else. So I pay attention to this thing for a second, and then I put it on pause and I pay attention to that thing, and then I put that on pause and I go back to this thing, and my brain goes, I'm pretty sure this is what happened over here when I wasn't paying attention to it, but I don't know for sure. And we end up with gaps in our understanding and our awareness. So I really like orienting myself, reminding myself and my patients to the idea that if something is worth doing, it is worth doing with all of your attention. And that can be a really helpful mantra to help bring you back to one thing in the moment if you're having a hard time and your attention is getting pulled in 10 different directions. This is a skill that takes a lot of time to develop, because look at how long we've been working on multitasking and getting good at that. All that we need in order to develop the One Mindfully skill is awareness of multitasking, patience with yourself, and willingness to direct your focus to one thing in the moment, again and again and again and again and again. We talked earlier about how people with trauma histories often avoid, but also often multitask purposefully in order to avoid being present with distressing thoughts and feelings. So focusing on just one thing at a moment can be really overwhelming for people with trauma histories, because it gives their brains the opportunity for those intrusive thoughts to push in. It's important to recognize distressing thoughts and feelings as distractions, and to use an inner narrator to increase your focus on the current moment and decrease opportunity for other distractions. So I've got a picture up of somebody washing the dishes. The inner narrator might say things like, I feel the sponge in my hand, the water's warm, it's soapy and bubbly, I can feel the foam of the soap. And that inner narrator fills up space in our brains so that we don't have as much room for those intrusive thoughts to push in. Keep in mind, again, for people with trauma histories, that this type of practice should initially be very short until they gain confidence with practice and built up over time. And it can also be paired with some of the distress tolerance techniques that we're going to talk about later, 5 senses, paced breathing, paired muscle relaxation, in order to deal with some of those unwanted side effects of being one mindful, like having intrusive thoughts. Next slide, please, Erin. So we're now talking about the effectively skill, the last but definite not least of the mindfulness skills. Effectively is about keeping a laser focus on your goals and what you're hoping to achieve. So in order to do this, we first have to know what we want to achieve. It can be really hard to be effective in reaching a goal or hitting a target if we keep moving it or if we don't know what we're shooting at. Sometimes we also don't know what we need to do in order to be effective. We don't know the steps we need to take. We don't have the skills we need. We have no idea how to get where we're going. Other times, it's something that can't be accomplished alone, and we need to ask for help in order to figure out what will work best. So going this alone and doing things totally on our own isn't always the most effective way to do things. The idea of playing by the rules in the effectively skill is an important one because it helps us to keep the focus on achieving our goals rather than putting the focus on others being us as cheating or things in order to get our needs met. In all of those cases, we end up with the focus being more about how we got there than the fact that we got there. And we're not looking for the focus to be on those things. We're looking to be as effective as possible in reaching our goals. Not playing by the rules can also really impact relationships as well and can cause hard feelings with other people. We want to make sure as we're being effective that we are reacting to the actual reality of others' behaviors rather than how we think they should be. So I have an example here with this, that you may have a boss that you think should be compassionate and understanding, but who actually really does not have space in their life or their brain for hearing about everything you have going on in your life, so long as you're showing up for work and you're doing what you need to do. So in this instance, if you need to take a day off, it might be much more effective to just tell your boss that you need a day off rather than giving them a long-winded explanation as to why and trying to invoke empathy if that's something that's just not going to be a motivating factor for them. And if you approach your boss as someone that you think they should be, if you want to have a boss who's empathetic and wants to know the ins and outs of what you're dealing with, and you approach that boss who really isn't that person in that way, they could get frustrated and annoyed because your long-winded explanation might be keeping them from other things they need to do. So effectively in that instance is to be short to the point and just move on with your day. Willfulness that's addressed here is going to be addressed in depth in our distress tolerance module for this afternoon. But willfulness is the idea of trying to control things that are not yours to control. Sitting on your hands, which is referenced in this handout, is the idea of refusing to do things that you know would be helpful to do, and just, nope, not going to do it. Both of these, being pushy and forcing things to happen that aren't meant to happen, or refusing to do things that you need to do, can both be forms of willfulness and can both be detrimental to effectiveness. All right, next slide, please. Ideas for practicing the how skills. You don't have to review all of these handouts, the A, B, and C, together with patients unless they're having a hard time figuring out how to apply these skills. They can be a really helpful reference for people if they have homework to work on these skills and they're not sure what to do, but they're not really necessary to go over with them in detail. In terms of exercises to practice with people, the close-up observations is one of my favorite. It's not referenced in the book, but this is where you find magnified images of everyday items online, and you can find a lot of them if you just do a Google search of magnified images. You show them the image and you ask them to give objective observations of what they see without making judgments about what the object is, which is very, very hard to do. And it's a great opportunity for coaching around what is non-judgmental and what's observe and describe, and what could be perceived as judgmental. The end part, which is really fun, is then allowing them to make purposeful judgments and guess what it is and let them know afterward what it actually is. And to use that as an illustration that sometimes we are spot on with our judgments, and there are other times where we couldn't be further from the truth, which is a great illustration of why the non-judgmentally skill is really, really important. Next slide, please. All right, we already did our questions section for mindfulness. I don't see any questions in the queue right now. If you think of any from the last 2 skills that we went over, actually we did 3 skills after the questions section. If you have any additional questions, please feel free to put them in and I can always address them at the next question break. And just to give you guys a quick orientation to where we're at, it's about 1:07 right now. We're going to be working on the crisis survival skills until about 1:40 or 1:45. I'll take some questions and then we'll do a 10-minute break at 1:50. We'll start back up at 2 o'clock with our last hour doing reality acceptance and talking about homework. Next slide, please, Erin. Oh, we can keep going. We already did that. Would you be able to push out the poll to people, please? And then we can move on to the next slide as well. So this is a poll about how many skills you have in your toolbox that you are able to offer patients who are managing crisis level urges, which is really what this module is geared at, just so I can get an idea of where people are at coming into this and how much you already have in your toolbox. So just looking at those results as they're starting to come in. And it looks like the majority of people are saying a few, but they're not always helpful. Or I've got a few that typically work. A few said none, and some said more than 3. So it sounds like a pretty good spattering. I'm really hopeful that after going through this module, you guys will have some solid ideas of skills you can take away that will be helpful working with patients who are in more acute distress and in need of help with getting that grounded. Can we keep going with the slides, Erin? So we just did that. All right, we're starting with the mindfulness. I'm excited about this one. This is one that we did in my intensive DBT training, and I had never done it before, and it made me feel super awkward, and I love it for that reason. So this is the cat head drawing. It's an encouragement to take a blank piece of paper. You're gonna put it on your head using a pen or a pencil. And you get to use your dominant hand with this one. There are some mindfulness activities that encourage you to use your non-dominant hand, but we're going to use our dominant hand. You're going to take about 30 seconds, and you're going to keep that piece of paper steady on top of your head, and you are going to draw a picture of a cat on top of your head, on the paper, not on your hair. As you are doing this, I want you to pay attention to your thoughts and your feelings and just notice what they are. So I want you to take 30 seconds. We're going to do our drawings, and then I'm going to talk about it. And by the way, you don't have to draw that cat in the picture. You can draw whatever cat comes to your mind. when you're done with your drawing, go ahead and take a look. And I want you to answer to yourself. Experience with this. What did you know in your rendition of the cat? And what were your thoughts and your feelings as you were looking at your picture? Just because I have no shame when it comes to mindfulness activities, I will share with you my picture, which I'm pretty sure most of you won't even be able to recognize as a cat. It has maybe some ears and a chin and some whiskers, and there are eyeballs, but it doesn't look like a cat. It looks very similar to my very first drawing that I did with this in my DBT training that I still have. I'm looking for it to see if I can show you. Yes, I do. It was very memorable. This can be a great icebreaker with people and not a great first session activity, which is why I did it later on in today's training. You want to have a level of trust built with your patients before you ask them to do something as awkward and bizarre as draw a picture of a cat on top of their head. So that was our mindfulness for the afternoon. Would you be able to move us on to the next slide, Erin? All right, so these are the handouts that we're going to be looking at for the next hour. Less than an hour. We don't have a lot of time. Distress tolerance handouts 1 through 9A. If you can move on to the next slide, and I'm going to get my book queued up in the right place. All right. So handout 1 identifies that distress tolerance is broken up into 3 primary sections. Only 2 of them are actually taught in the standard curriculum for DBT. The first is crisis survival strategies, which are designed to help us get through highly stressful situations without making things worse. The second is reality acceptance skills, which help us to find relief from unnecessary suffering and open doors for charting a path forward. We're going to be going over those after our next break. And the ones that we won't be covering, but I encourage you to look at if you feel they would apply to your patients, are skills for when the crisis is addiction. And they can be really helpful for patients struggling with substance use, eating disorders, compulsions, or other addictive behaviors. Next slide, please. So, overview of crisis survival skills just gives us a quick inventory of the skills that make up the crisis survival strategies. These are all skills we're going to be covering over the next several slides, and that should be a part of any distress tolerance curriculum. I often teach these skills piecemeal very early during the treatment process, especially during early assessment, because if I'm seeing someone sitting in front of me who is in acute distress, I'm not going to say to them, you know what, I haven't finished my psychosocial yet. I can't work on skills until we have that done. I'm going to teach them the stop skill. I'm going to teach them the tip skill. I'm going to teach them different options for managing things that are going to help them to be more present for that assessment process. So that doesn't mean that I'm not then going to cover them when we get to skills training, but I might do a smattering of them early on to help stabilize things. Moving on to the next handout, or the next handout and the next slide. All right, handout 3, when to use crisis survival skills. So the first part of this handout defines what a crisis is, because you need to know what a crisis is if you're going to know when to use these skills, right? And different people have different definitions. So crisis situations are situations that are highly stressful, short-term, and create intense pressure to resolve the crisis now. Short-term can be a relative term, but it implies that there is a light at the end of the tunnel, or at least some point at which you can predict that there will be relief. The next two boxes are going to highlight when to use or not use crisis survival skills. There are absolutely times when crisis survival skills either won't help or won't be appropriate to use, because they can make things worse if you use them inappropriately. So an example of this, just briefly, is a situation where there are clear steps that you need to take, that you are capable of taking right now in order to solve a problem or make things better, and you haven't done those steps yet. If you're going to use some of the distract or self-soothe skills to the exclusion of working on solving the problem's still going to be there, and it's going to get worse, potentially. So crisis survival skills will not solve problems that are causing you distress in the first place. And they can absolutely be helpful in lowering and managing your distress temporarily. I have people say to me sometimes, you know what, I tried the tip skill, I tried paced breathing, and it only worked for like 5 minutes, and then it came right back again. It doesn't work for me. And I say, it totally worked for you. You got 5 minutes out of that? That's awesome. Because 5 minutes is enough time to use some of the more complex skills that can help get you closer to resolving the problem. These are not skills that are meant to provide long-term relief. They are a Band-Aid, and they are meant to patch things together until we can use more complex skills that are going to make the situation better in general. So my example here is distress related to not having the money to pay the bills. If I am really stressed out, and actually maybe a better way for me to put that would have been distress related to not remembering to pay the bills, because not having the money, a little bit of a different problem. But if I'm worried that I'm not going to remember to pay the bills and I've got the money to pay them, if I put that off, the distress is there to alert me that I need to do it and remind me that it needs to be done. And once I do it, that distress is going to go away. If I'm using distress tolerance skills and not getting the bills paid, I'm not doing what I can to relieve that situation. I may need, if I am beyond what we call our skills breakdown point, which is the point at which either we can't think of anything effective to do, or if we try skills, they're not going to work because things are just too far gone for us distress-wise and emotionally. If I am really spun out because I'm so anxious that I'm going to forget, I might use distress tolerance skills briefly to get things down to a manageable level so that I can think my way through how to do it. And I need to still pay the bills once the distress comes down, or the distress is going to go back up again. Next slide, please. The stop skill. This is an old standby, and this is a great skill because it's super simple and it's got a great visual that goes with it. This is one of the foundational skills in distress tolerance, because use of the stop skill, even if you're not aware that you're using it, is necessary in some form in order to use any other skill effectively. So, except for maybe participate, because we don't stop what we're doing when we're participating, we just participate. But STOP is an acronym. We're going to start diving into the acronyms of DBT. Hold on to your hats. So the S is for stop what you are doing. Freeze, do not move a muscle. The T is for take a step back. Get perspective, zoom the lens out. The O is for observe. Use your observing and the mindfully, namely with your wise mind. So you want to read that through with patience and discuss. You want to also discuss the potential for you to make things worse if you don't pause and look at the big picture before you leap. And how we can sometimes make decisions that we later regret if we leap before we look. This can be a skill that can be super helpful in so many situations and can be really hard to remember to use when we most need it. For that reason, I really encourage people to use visual cues and reminders for this skill. You can use a picture of a stop sign. You can draw a stop sign. I had a patient once who drew a picture of a stop sign on a Post-it note and put it on the steering wheel of her car because she got road rage a lot and she didn't want to do anything that she would regret. I had another patient who changed the picture of someone that they were prone to angry texting. In their contacts, they changed the person's picture to a stop sign. So they would see the stop sign every time they went to text them. Other people save this as a background on their phone, or I've had people post it on their refrigerators, on their kitchen cabinets, wherever it needs to be that you are most likely to need it. Let's move on to the next skill, which is going to be handout 5, and then the next slide. So we're looking at pros and cons now. This is one of the anomaly skills in the crisis survival strategies, because this is one that's more designed to be used in a cope ahead fashion, rather than using it in the moment, like the heat of the moment. This is something that can be really, really helpful if you do it ahead of time, and then have a copy of it with you when that crisis arises to remind you of the pros and the cons of reacting skillfully and of not reacting skillfully. So keep in mind, as we're looking at this, this is asking us to identify the pros and cons of acting on crisis urges, aka not responding skillfully. Crisis urges might look like cutting, burning, yelling at someone, ending a relationship in anger, you name it. And crisis urges don't just have to be big attention grabbing behaviors. Crisis urges can be to withdraw, to avoid, to put things off. And these can also be really self-sabotaging behaviors, and can be damaging. So identifying those not so big behaviors as crisis urges as well can be really important here. Any unwanted or ineffective crisis urges can benefit from pros and cons. Crisis urges are the strong compulsion to do something in the face of a crisis. And we wouldn't be having those urges if they weren't potentially helpful in some way. So there are elements of most, if not all, urges that will serve a purpose, and acknowledging that purpose is really important in order to make a balanced decision about how to proceed. One would think that, like, what could be the possible positives of cutting yourself? And reality is that cutting behavior serves a purpose for the people who do it. It's really unhealthy in a lot of ways, and it's a hugely increased risk factor for completed suicide. And it's something that can help people to feel in different ways. It's something that can help people to numb in different ways. There are a whole host of things that provide relief for the people who do them that we might not understand not being in their shoes. So giving them an opportunity to identify clearly, not just what they think you want to hear, but the reality of what are the pros and the cons of acting on those crisis urges is really important and can help you to more effectively address things that might actually be reinforcing those behaviors to continue. Let's see. When we identify the pros and the cons of both acting on the crisis urges and resisting the crisis urges, it can help, again, to kick in that prefrontal cortex, have some balance between the emotional and rational parts of our brains, and give us the space to make a balanced decision about how to move forward. So my example here is that my urge sometimes in crisis situations is to overfunction, or to do way more than is needed in that situation, because I tend to be a little bit of a perfectionist sometimes. Not helpful, I get it, I'm working on it, and it's where I go. So the pros of acting on those urges are that they help me to get a lot done in a really short time, which can be awesome, and I get reinforced for it, and I get like that dopamine hit, and it leaves me feeling exhausted, and it frequently leads to me being late for things. So pros and cons of acting on that crisis urge. Resisting that crisis urge is going to have its own set of pros and cons that may not look like a mirror image, but in opposite of the pros and cons of acting on the crisis urge. So it's really important to identify both. Important to review pros and cons before a crisis urge hits, and to rehearse them over and over. If there are problem areas that you have identified with patients are likely to reoccur in the future and need some skills for stabilizing. All right, I think we got through pros and cons. Let's head on to the tip skills. And I'm just looking ahead to how much we have because I'm trying to pace myself. I think we're doing pretty darn good. So with the tip skills, changing your body chemistry. This is a super weird DBT acronym, especially because it's called TIP, T-I-P, but there's two P's. So I don't know. And the skills are weirder than the acronym, I promise you, and they totally work. So the tip skills are what I call the skills version of Xanax, because they're quick, they don't take long to do, they have a very direct physiological impact that absolutely lowers acute distress without some of the unwanted side effects of medication, which is why I love these skills. We're going to discuss the cold water tip in detail in the next handout, so I'm not going to go into it in detail here. But I will say that out of all of the tip skills, cold water tip is the one that I'm going to reserve the most for situations where people are in such acute distress that distraction is not going to cut it. And there's not the ability to do exercise or the willingness to do exercise, and you can't coach them through breathing, or their ability to even alter their breathing pattern is so far gone that it's just not going to happen. So Cold water tip is something I have reserved for those really acute situations, and it can absolutely bring things down really quickly. For all of the tips skills, and I'm going to say this multiple times, it's a big directly, and in particular, your heart, your cardiovascular system. And if someone has a known cardiovascular problem, heart condition, low blood pressure, any number of cardiovascular conditions, please ask them to consult their doctor before trying these skills, because especially the cold water tip skill lowers blood pressure and lowers heart rate very dramatically and very quickly, and can cause medical crisis if someone has pre-existing conditions. That said, intense exercise, any activity that will purposefully raise our heart rate for 10 to 20 minutes. I know cold water tip is about lowering heart rate. Intense exercise is about raising it. Two ends of the same spectrum, and they both have benefit. This helps to release endorphins that are associated with a runner's high, and that can help to complete a stress cycle. Great podcast recently and related book that I've been listening to about completing the stress cycle. If anyone wants information on that, I'm happy to share it at the end of the training. But helped me to make even more sense of why this is a skill that works and why it makes sense. But being able to exercise in any way that is going to raise your heart rate for 10 to 20 minutes can really dramatically impact your experience of distress. Paced breathing, the first of the P's, is the idea of not forcing big, deep in-breaths, because is a gasping reflex that we do when we are like terrified of something or highly distressed, and asking someone to lengthen their in-breath when they're acutely distressed can actually send a feedback loop to the brain that makes things worse. So the idea is to breathe in at whatever rate the person feels is natural at that point in time, and to breathe out longer and slower than they're breathing in. So if you compare this with getting them to count in their heads at a regular rhythm at the beginning of each in-breath and from the beginning of each out-breath, 1, 2, 3, 1, 2, 3, 4, 5, you want to get them to breathe out for 2 counts longer than they're breathing in. This is a pattern of breath that our bodies fall into as we prepare for sleep. And it is a pattern of breath that sends a message to our brains that we are safe and it is okay to relax. The other P is paired muscle relaxation, which does have a script found on handout 6B, or can be done in a modified format. You can kind of freewheel this one and it's okay. The idea is to progress through each of the major muscle groups in your body, making sure not to forget your face, because our faces are hugely affected by our emotions, and there is a reverse feedback loop when we change our faces that tells our brains to feel something different. And this is not like paste a smile on your face. This is about, rather than trying to relax your face, because we can't just force ourselves to relax, that's like, doesn't happen, tends to increase tension and distress. We're going to systematically go through each major muscle group and tense. This asks for, I believe, I'm going to look to the count of 3. No, to the count of 5. Sorry. I'm looking all over the place. Hold the tension as you inhale for 5 to 6 seconds. You can actually do each one for up to 10 seconds with great benefit. And the idea is to purposefully add tension to those body parts and then release. And when you release that added tension, it releases some of the earlier tension with it. The paired piece in paired muscle relaxation is when we choose a cue word to pair with that release of tension, that in the short term is going to make no difference to our experience. It's not a lot of extra work to do, and it's not going to help a ton either. And in the long term, the more that we pair that same word over and over and over with that physiological experience of release of tension, the more that that word becomes a cue word for release of tension. And the more over time that you will find that just thinking about that word can cause your body to release tension, which is super cool. It's a little bit of a conditioned response that develops. The suggestion in the handouts is to use the word relax. I'm personally not a fan of the word relax because many of us get the comment, oh, just relax. And it becomes a very emotionally charged word, for lack of a better term. So I prefer the word release over relax, but I really strongly encourage patients to pick whatever word makes the most sense to them. You can use the word cupcake for all it matters, and it will still work as long as you use that word every time. I just suggest that the word that you use be a somewhat neutral, if not pleasant word. So that's the tip skills. Cold water, intense exercise, pace breathing, paired muscle relaxation. Next slide, please, if you will. We're going to talk about cold water tips step by step. So there is a caveat printed at the bottom of the page that cautions about using these skills for people with certain risk factors. I personally was not aware that there was such a thing as allergy to cold. Apparently there is. They don't recommend using this if that's the case, or if someone is on a beta blocker, they do not recommend using cold water tip. Please remind people of this just so you don't end up with an unfortunate medical experience. What the cold water tip skill does, which is super cool, is it triggers the dive response, which is a reflex in our bodies that is designed to help us dive deeply into cold water. And it is triggered by having conditions similar to actually diving deeply into cold water. It can provide a very rapid decrease in heart rate, blood pressure, and a slowing of the thoughts. 20 to 30 seconds is all that you need in order to get benefit from this. This can be highly effective during times of intense agitation, and it can be really aversive. So be aware of this and weigh the pros and the cons. It can feel super weird and uncomfortable to plunge your head into a bowl or basin of cold water. Not only just because it's a weird thing to do, but also because the next thing that usually happens once you get past the weirdness of it is you start having panic thoughts because time slows down in your head. And it feels like you've been in the water forever holding your breath and, oh my gosh, I'm going to drown. This is normal. And orienting patients to these phenomenon is really important so that they don't try it and go, oh, I'm never doing that again. That was horrible. This is normal. And if they can get to the end of it, I do recommend that people set a timer, because that sense of time is going to slow down when you do it. If you can get to the end of it, they are huge. If someone is not willing or able to plunge their head into cold water as a result of using the cold water tip skill, is to fill up Ziploc baggies, fill up 1/2 of the way, seal it, and put it inside another bag, double bag it. Keep it in the fridge. And that keeps it on hand, especially if you can run it under cold water for a second before you do it. And then you're going to put your legs apart in a seated position in a quiet location. Put the baggie up to your face, covering the eyes, forehead, and cheeks, and lean forward with the head down towards your lap. So it replicates kind of that diving position. You can also use those gel ice packs. Just put a paper towel over top of them, preferably maybe a wet one, because you don't want to get freezer burn on your face doing this. You want it to be cold, but you don't want it to burn your skin. And you can also use a wet washcloth that's cold. You can use frozen vegetables. You know, there's a lot of different things. Get creative and see what works. Moving on to the next slide. Paired muscle relaxation. I'm not going to go through this in detail, but it provides some really helpful information at the top about the practice. And it can be most effective if it is read by someone other than the person who's doing it, because ideally, like, you're focusing on what you're doing, you're not referencing what you're reading while you're doing it. And if you can make sure to keep, as you're reading it, and this goes for this meditation as well as any other meditations you're going to be using, what we call a late night DJ voice. So you want to talk really calmly and not have a lot of fluctuation in your voice tone, which can also be really helpful with creating that sense of safety and relaxation and decreasing distraction. The script here does not have to be followed to a T in order to be effective. You just need a systematic tensing and releasing of each of the major muscle groups. And this can also be a super effective way to complete the stress cycle. If exercise is not readily available, it obviously isn't going to give you like the strength training and the cardiovascular training that exercise does, but this is not about exercise. This is about distress tolerance. And as in terms of distress tolerance, paired muscle relaxation can be just as effective. All right, moving on. Next slide. We're skipping over 6C. Can also be a really helpful one to do with your patients, but not necessarily a part of the standard curriculum, so not always one that I get to with everyone. We're moving into the distract skills. So distractions are something that most of us look to avoid a lot, right? Especially when we're trying to be mindful. But in the context of distress tolerance, distraction can actually be a really helpful skill. Distraction that is done mindfully for a predetermined amount of time is what we're looking at here. Spending all of our time on distractions, like if I'm going to play video games all day long, I am going to have a really rough time building a life that I can feel good about. And being able to play video games for 5 or 10 minutes when I really need to settle myself might really be helpful. So it's finding moderation and finding a balance between what's helpful and what else needs to be done. I like to go back to that approach and retreat metaphor that I used, or the strategy that I referenced when we were talking about mindfulness and how you approach kind of like waves coming in to the shore as a tide is coming in, and then the wave goes back out to the ocean. So each time that wave approaches, it just touches that thing that's hard, that thing that's distressing, or that thing that's upsetting, and then it goes back out. And the retreat is distress tolerance, is finding a distraction for a while that can feel safe and can feel okay. It is not retreat as in I failed, I'm running away. It is retreat as in I'm recharging my batteries. There are 7 categories listed here that can all provide some really great ideas as far as ways to practice the distract skill. This is not an exhaustive list, and pretty much anything that is going to be done in moderation without causing damage can be helpful. Making comparisons, which is the 3rd category down, is the one that is most frequently challenged by patients. Because it says things like, think about people coping the same as you or less well than you, or compare yourself to those less fortunate. These can be helpful some of the time to some people. Some people who are empathy sponges do not benefit from this part of the skill. And in fact, it can make things worse, because when they think about others who are less fortunate, they just turn into a puddle. And it's horrible, and it triggers more emotions, and it's just a vicious cycle. So in those instances, being able to compare how they're doing now to other times in the past when they have struggled, but they've gotten through it, can sometimes be a helpful coaching skill. And there may be some people for whom the comparison category is just not going to be their go-to skill. And that's okay. There are going to be some people who are like, oh my gosh, yeah, I love watching daytime soap operas because I watch them, or Jerry Springer or Dr. Phil, and I see how bad life could be. And I'm like, my life's not so bad after all. It's knowing your patient and taking their feedback and working with it. Moving on to the next handout. And I'm being aware of the time. We are going to get to, we've got a break coming up like ASAP. We've just got a couple more handouts here. I'm going to go through. I will give you guys a full 10-minute break, but we may go just a couple minutes over before the break time, if that's okay. Self-soothing and body scan meditation. The idea here is to focus on your 5 senses. This is broken down by the 5 senses, and find experience for each of your 5 senses that can be pleasant. This is not an exhaustive list. But it is meant as a means of spurring more creative thought about options. It can be helpful for self-soothing as well as distract and improve the moment, which we're going to be getting to in just a minute, to ask patients to check off items that they've already tried and benefit from, that they want to use more of, and to highlight items that they haven't tried and would like to. Body scan, which is addressed in the body scan meditation, is kind of a foundational piece of mindfulness-based stress reduction, which is also an evidence-based practice. Again, for patients with major trauma histories, especially physical or sexual trauma, body scan can feel very, very threatening and may not be the skill to push with those patients. Take their feedback for what it's worth and be respectful of it. There are a lot of recordings online that can be helpful in terms of self-soothing. And I think I covered everything from this slide. So let's go ahead and move on to the next slide. improve the moment and sensory awareness step by step. And then we're done with this section. So this is the last part of what I think of as the group of distracting skills. Distract, self-soothe, and improve the moment. It's very similar to the previous two, but it focuses on ways to briefly distract yourself from the present moment in a pleasant way, but a different perspective. The starting working. So this is for your more chronic distress types of situations. And I'm seeing that my internet connection is being unstable. I think I'm back online. I apologize. I'm just going to repeat that these are improve the moment is skills to use that can be really helpful for long-term or chronic distress, more so than short-term. Can still be helpful for acute distress, but can be very helpful for long-term chronic distress. Giving opportunities to practice the skills can be really helpful, can give you some great fuel for mindfulness activities. And the sensory awareness step-by-step is not a required part of the standard DBT curriculum, but it can be really helpful to orient participants to and to use as a mindfulness activity. It's also a great grounding strategy for when distress is high but not out of control. 5 senses is one of my personal favorite sensory awareness activities. So we're going to guide participants. I know a lot of you are familiar with this already. You guide participants to label out loud 5 things they can see, 4 things they can physically feel with their skin, 3 things they can hear, 2 things they can smell, even if they have to lift something up to their nose to smell it, and 1 thing that they can taste or notice the absence of an expected taste. So great grounding activity and can honestly be really helpful, especially the more detailed you ask people to get with it. So I'm asking, which crisis survival skills are you most likely to use with your patients, or to try at least? You may want to use all of them. I don't know if it gives you that option or not to check all of them, but if there's one that stands out more than the others that you think you would likely use with your patients, if you can let me know, that would be really helpful. Looks like we're getting a pretty good distribution of things. Distract, self-soothe, and improve the moment are winning out at this moment, but stop and tip are right up there. So looks like a pretty good distribution and smattering of the skills. Helpful for me to be aware of, and I definitely wish you guys luck in practicing these skills with your patients over the next couple of weeks. So we are going to move in next to the skills for reality acceptance. If you can move our slides along, Erin. We are looking at, oh, if you can jump back for just a second. Handout 10 through handout 15A is what we're looking at here. These are some really related and connected skills that build on each other, and it's hard to teach these skills in isolation from one another, at least up through 14A. 15 is a little bit different, but 10 through 14A really kind of build on each other and are necessary to have together. So we'll see where we can go with this. If you want to move on to the next slide. Yep, handout 10 is just an overview of the reality acceptance skills. So this is for a brief review as an orientation to the skills that make up reality acceptance. And like I said, most of these skills are interconnected, and it can be helpful to teach them together. The idea behind reality acceptance is that in trying to avoid being present with painful experiences, we sometimes make things worse for ourselves and more painful in the long run rather than less. So the more that we avoid being present with reality as it is, the more that we have the potential to do damage, or to interfere with things that are important if we were to acknowledge that reality. So by learning to acknowledge and be present with the reality of difficult experiences, we position ourselves to find a way forward and prevent unnecessary pain and suffering. It is important to recognize that pain is a normal part of the full continuum of human experience and serves a very important function. Many times, it serves the function of bringing our attention to things that are important, that might be unsafe, that might need our attention, or that might need to be protected or cared for. By not being present with these things, by numbing that pain or not acknowledging it, we absolutely have the opportunity to do more damage. So this skill set, I want to frame as one of the most difficult to teach in my experience in all of the DBT skills. Many patients who have a history of painful experiences, again, adopt avoidance-based coping strategies, and these skills are going to run completely counter to those defense mechanisms and survival strategies. Be prepared when you teach these skills for the possibility of intense reactions from your patients, and make sure to smatter lots of validation for the emotions that they're experiencing and the reasons that they're experiencing those emotions along with your teaching of these skills. I think one of the most challenging experiences I had with these skills was in a group where one of the group members was going through a major medical illness and was very worried about what that meant for her and her family. It was potentially a terminal illness. And learning these skills felt like an incredible threat to her, because even acknowledging that she had that illness was just overwhelming. And what that meant for her family was just overwhelming. So these skills have the potential to really be a huge challenge. And I can also say that that particular patient and many others that I've worked with, once they have been able to get to a place where they can be present with these skills, have actually been really thankful for them and have said that they have been some of the most powerful skills that they've used. I'm wondering if I'm, am I back? Would you be able to move me on to the next slide? Gotta love technology. I apologize. Was wondering why that slide wasn't changing. So radical acceptance. This is the truth bomb in DBT. This is a super challenging skill for most people to learn and apply, and I would recommend teaching it, or not teaching it, but encouraging use of this skill and teaching it only during times when someone is below their skills breakdown point. So they are not so far gone that they just can't manage, they can't, wrap their brains around any other skills. This is a hard skill, and this is something that requires mental and emotional resources to teach effectively, to use effectively. This is not something where someone is in the throes of crisis and you say, you know what, you just need to accept what's going on, because you could get punched in the face for that. So this is something to be approached gently from an approach and retreat standpoint. You're going to use your crisis survival skills first, and you're going to help them get grounded. And once they're a little more grounded, then radical acceptance is something that maybe you start to introduce. All of the boxes in the radical acceptance handouts are really important to review in detail with patients. Please keep in mind and frequently remind your patients that not everything has to be radically accepted. If you would need a magic crystal ball to see something, or if there's something that you can do right now to change the situation for the better, then radical acceptance of what's happening right now is not the skill to be using. Please remember, radical acceptance does not equal approval of the facts or of the situation. It just means that you are acknowledging what is a fact, not that you're okay with the facts. Keep in mind that pain is a normal part of our experience as human beings and our body's reaction to get our attention and communicate important messages to us. Suffering is the unnecessary emotional pain that comes with refusing to accept the reality of our current experience and the thoughts related to that lack of acceptance. So the ostrich with its head in the sand. Ostrich is out on the savannah. It wants to be safe. It sees a predator approaching. If that ostrich sticks its head in the sand, that doesn't mean that it's not still going to get attacked by a lion. It means it's just not going to see it coming. The same is true with people and with radical acceptance. We can choose to not accept how things are, and that doesn't mean that we don't still have to deal with the consequences of those situations. Sadness can very frequently be a part of radical acceptance that happens after we practice this skill. Sadness means that we are letting go of something that we wished were happening, that we recognize we can't have. And if you can stick with the sadness and work your way through it without fighting it, deep peace and calmness typically follow. Let's move on to the next slide. Factors that interfere with radical acceptance. 11A. It is important to validate the visceral reaction that some people have to radical acceptance and to counter that reaction by helping them to check the facts. Encouraging patients to identify which specific factors interfere with radical acceptance, most for them, can help with targeted work and problem solving. Working through these issues in a group setting can really be helpful to other group members if you have time to do it, and even if you're only getting through it for one person's issue, because it shows them the process for how to do it. Keep in mind, if things get too involved as you are helping someone work through the process of radical acceptance, it may be helpful to refer them back to individual therapy and to keep in mind the needs of the group as a whole. So the MapQuest metaphor that I use here, I don't know if any of you remember MapQuest that we used before we had these devices with navigation systems on them where we don't necessarily have to plug in what our current location is because it finds it for us. But back when we had to go to a website and check out directions for how to get where we wanted to go, it asked us to type in where we are and where we want to go. What's your current location and what's your destination? I'm not going to get accurate directions to the place I want to be unless I acknowledge where I'm starting from. And where I'm starting from may not be where I want to be. And it might not be a place that I want anyone else to know that I'm at. And that doesn't change the fact that I'm there. So not wanting to acknowledge where you're at can absolutely be a huge factor in struggling with radical acceptance. We're going to move on to 11B, practicing radical acceptance step by step. Start with acknowledgement that you're fighting reality. So start with acknowledging that you're not radically accepting. Should or shouldn't can be red flags to look out for. Encourage your patients to identify factors that led to the unwanted situation. So what happened first? What happened beforehand that led up to this? And make sure to help them challenge judgments with objective observations. So it's not that he was being a jerk, it's that he said this to me. Remember, we can examine the past and learn from it, but we can't change it. So the past is something to be radically accepted. Going through the motions of behaviors you would use if you did accept the facts repeatedly can be very effective in increasing acceptance. Being able to rehearse not just how horrible and bad it would be if things happened in the future that we're worried about, which makes our anxiety shoot through the roof, but how you would deal with those things as skillfully as possible can significantly lower anxiety and distress. Our stress is held in our bodies. There is no disconnect between our bodies and our brains. They are one and the same, and our emotions happen in our bodies. Focusing on the body sensations that we have as we're feeling distress can help us to address the effects more directly and appropriately through paired muscle relaxation, exercise, and other activities. Fighting emotional responses that accompany radical acceptance can lead to feeling stuck in those emotions. It's really important to remind your patients of how important it is to allow themselves to experience difficult emotions safely in order to resolve them. Emotions can be tunnels that we need to go through in order to get to the other side. If we get stuck or we go halfway and turn around, we don't ever get to see that light at the end of the tunnel. Encourage focus on how to integrate their new reality into their goals. Which goal that can take some work. Like if their goal is to graduate from college and they just failed 3 classes. So being gentle with people and helping and coaching them to integrate their new reality into their life worth living goals is an important part of radical acceptance. I'm realizing as I'm talking through this that some of this is related to that idea of completing the stress cycle that I referenced earlier. And I forgot to share with you guys the podcast and the book that were related to that. These are not DBT materials. I first heard about this through the Unlocking Us podcast. That's Brene Brown's podcast. The date for that was October 14th of 2020. That is a free podcast. And it's titled Brene and Emily and Amelia Nagoski on burnout and how to complete the stress cycle. The book that's related to that, which I'm reading right now and is fantastic if you get a chance to pick it up, is called Burnout: The Secret to Unlocking the Stress Cycle by Emily and Amelia Nagoski, Nagoski. So I hope that's helpful to people. Can we move on to the next slide? I'm going to put in a plug for another listen that I had on the Unlocking Us podcast, and I should have looked this. I'm shooting myself here. It would have been helpful if I would have looked this one up ahead of time as well. This was also on Unlocking Us. This was based on an interview between Brene Brown and Sonia Renee Taylor, and in reference to her book called The Body Is Not an Apology. This is a concept that is, again, not a DBT concept, and something that I have found is absolutely helpful, important, and fits well with the concept of radical acceptance. Radical acceptance in and of itself is a really bitter pill to swallow. Sometimes it can feel a little closer to chemotherapy. It can be painful. It can have some really unwanted side effects. Our willingness to practice radical acceptance can hugely be impacted by our practice of radical self-love. So the idea here is that radical self-love is about acting as a kind and loving adult and or parent toward yourself and toward the younger parts of yourself that are reacting in that moment, and providing yourself with the things that you need in order to be okay. Might include caring, patience, kindness, encouragement, can include things like stretching, can include lots of different things, in order to move forward from the things that you didn't want to happen. So the idea here is not just to cram it down your throat that like, this is reality, suck it up, deal with it, move on. But this is really hard. And what do you need to help you get through this? Because I know this is hard, and you know, I'm here and we're gonna get through this. So that is a very, very brief overview of radical self-love. I encourage you to take a listen and see what you think of that on the podcast as well. I'm not affiliated with Brene Brown. I am a huge fan though. All right, next slide. Turning the mind. So this is how we get from not being in radical acceptance to getting closer to radical acceptance. This is a skill that can help us get on that road when there is a huge gap between where we're at and where we need to be in order to be radically accepting. And it validates that radical acceptance is not something that happens automatically, but can involve a journey. Sometimes it is something that we can get to within a few minutes or an hour. Other times it takes months or even years to get to radical acceptance around things that are really intensely painful. Radical acceptance and turning the mind toward radical acceptance starts with observing that we are not accepting the situation. Look for red flag words that denote lack of acceptance, such as should and shouldn't, can't or won't. Recognize what steps will lead you towards acceptance and what steps will lead you further from it. Make a commitment to take the steps that will lead you toward acceptance. This is not a one-time deal. This is something that needs to be practiced sometimes over and over and over and over in order to see benefit from it, especially if the chasm between where you're at and where you want to be is wide. Moving on. I'm not going to say we're in really good shape with time because every time I do that, I go over. I won't say it. All right, willingness. So this can be a confusing concept to teach because it talks about the difference between willingness and willfulness. And I personally am frustrated by how similar those words are, which can be very confusing to people. And once they grasp the difference, it can make sense to them. So willingness is a state of mind that allows the possibility for things to improve and allows us to play the part we need to in taking action towards improvement. It's being open and ready to control that which is ours to control. So walking through an open door that's in front of us and has been presented to us, or closing a door that we know we need to close. I'm speaking metaphorically here, of course. Willfulness is the idea of attempting to control things that are not ours to control, or refusal to control things that we need to control. So it can look like two really different things, and both are willful. Both are refusal to do what's going to be effective. We referenced this when we talked about the effectively mindfulness skill earlier. You cannot successfully overcome willfulness with willfulness. And as you can see in the picture, 3 men trying to drag a giant cow through a gate, and doesn't look like they're getting very far. When willfulness is the issue, it is frequently because there is a response going on to some sort of perceived threat. Being able to ask, what is the threat? And helping that person to check the facts, or helping yourself to check the facts, to determine if it is actually a real threat or what the likelihood of that threat is, can make a huge difference. If there is a perceived threat that there's a possibility of, helping them to problem solve to find a more effective way of responding to that perceived threat might be needed. So we're going to move on to half smiling and willing hands. Half smiling. Actually, I'm going to back up and say both of these skills are based on the idea that our emotions loop that goes in both directions, that that feedback loop can absolutely influence our experience. Purposefully making changes to our posture or our facial expression can send a message to our brains to calm and to be more open. Half smiling is the practice of consciously adopting a facial expression that we would have if we were genuinely thinking about something amusing or a private joke. So it's turning the corners of your lips up just a little bit, having a little bit of an amused look on your face, not clenching teeth, not forcing a grin, not tensing your tongue against the roof of your mouth, and playing around with how each of those things feels can be helpful. I wanted to add in the Mona Lisa because she embodies the half smile to me. Just looks like she's got that little private grin going on. Having a thought you can go to in order to create that half smile in a genuine way can be really helpful in trying to use this skill. So for me, my half smile go-to is thinking about my daughter when she was really little, and she thought that cupcakes were called pupcakes. And I thought that was the cutest thing in the world. So I did not correct her for the longest time. And she doesn't hate me for that now. So that's an added bonus. But every time I think of cupcakes, I just get a smile on my face, even if it's a little private smile. And it can really help with that, that physical experience, feeling like it's coming from a genuine place. I encourage my patients to find their own examples of things in their lives that if they think about them, it's gonna bring on that smile. For one of the people I work with right now, it's thinking about what it was like when we first practiced paired muscle relaxation together, because we were laughing hysterically and felt ridiculous as we're clenching and doing all kinds of weird contortions. And every time I bring that up, she'll smile. So that's one of her go-to thoughts. But having their own things that they can connect with is really, really important here. Willing hands. Willing hands is a posture, and I'm trying to get into willing hands right now. Turn my monitor so you can see. Oh, maybe not. Willing hands is the practice of turning your palms up with your thumbs out, your hands unclenched. And it's a very accepting posture. Chest open as well. It is a posture that is adopted in many spiritual practices, and it's associated with openness to the universe, to our surroundings, and to a higher power. Use of willing hands communicates a desire to be open and accepting to our brains and to the emotional parts of our brains. Handout 14A is a page and a half, and that's going to give some examples of ways to practice half smiling and willing hands that can be really helpful. All right, mindfulness of current thoughts. If we can move on to the next slide there. Thank you, Erin. Mindfulness of current thoughts is going to move away from the more reality acceptance related skills. And this is going to address thoughts more directly, because our thoughts very much impact our emotions and behaviors, whether or not we're aware of them. So mindfulness of current thoughts encourages awareness and objective observation of our thoughts with interest and curiosity and possibly some playfulness. And the reason that this is under the reality acceptance skills and not like the crisis survival skills or somewhere else in distress tolerance is because sometimes our thoughts just show up, especially intrusive thoughts and flashbacks and things along those lines, and they can be really distressing when we can't get rid of them and they won't go away. So this is the idea of really changing our interaction and our relationship with those thoughts and approaching them from a different perspective. So keep in mind here as well, going back to that CBT triangle, that our thoughts can be really painful at times, and those thoughts won't physically harm us and won't physically harm our relationships. Our behaviors can harm both of those things. So finding ways to interact with our thoughts differently and to separate those thoughts from our behaviors is really important. Repetitive thoughts or ruminations typically arise when we are trying to avoid feeling uncomfortable emotions. So it is an effort on the rational part of our brain to go into overdrive to try and overcome what the emotional part of our brain is feeling. Can feel really overwhelming when it happens. And just like our emotions, and we're going to be talking about this a lot in the next training, when we try and block out our thoughts, the effect can be the opposite, and it can sometimes make them get louder and bigger because they're there to serve a purpose. And if we're not allowing them to fulfill that purpose, they're going to get bigger. So the idea here is to observe your thoughts, and it gives lots of ideas of how to use the observe skill in regards to your thoughts. To be curious about your thoughts. Curiosity is something that's absolutely associated with engaging the prefrontal cortex and using your wise mind. Remembering that your thoughts are not you, that they are something that happens as a part of your experience, and they don't define what your personality is or who you are as a person. So it gives the idea here of trying to love your thoughts. This can be a really hard one for a lot of people, especially if they do have intrusive thoughts or flashbacks or things along those lines. What I like to orient patients to here is the possibility of loving the function that those thoughts might be playing. So to alert you to something important, to motivate you for action, or to orient you to important past related events. And to love that those thoughts are trying to help you be safe or keep your goals in mind or your values, or maintain connectedness with the people around you. You can love those functions without loving the experience of having those thoughts. Let's see, what do we have for our next slide, Erin? All right, so practicing mindfulness of thoughts. Any mindfulness practice is going to take effort and repetition to strengthen. This is no exception. It takes a lot of practice to do this. In really stressful situations, and I'm starting to adopting a playful or comedic stance toward your thoughts can sometimes help you to feel your thoughts to feel less heavy and more manageable. So like imagining your thoughts being bouncing balls, or like, oh, there they go again, they're bouncing. Keeping in mind that the idea of not believing people's thoughts or having inaccurate thoughts can sometimes feel very threatening to some patients, which is why in DBT we focus on validation just as much as we focus on behavior change. I encourage you to tread really lightly and encourage patients to offer examples of times when their thoughts have been off base rather than pointing out to them that's an inaccurate thought. Because they can typically come up with examples if asked that feel less threatening to them to bring up of times when their thoughts might not have been right on par. And that can lead them to be a little more accepting of the idea that maybe not all the thoughts they're having right now are on par either. Use of metaphors to describe the nature of our thoughts can be really helpful in getting distance and perspective. I really encourage my patients to come up with their own metaphors for how to relate to their thoughts if the ones in the handout are not relatable to them. My favorites personally are my thoughts as race cars on a racetrack that they just zoom by and then they come around again, or like horses on a carousel, or like billboards on the highway that I'm driving by at 70 miles an hour. There are lots of different metaphors you can use here. I encourage you to look at what's on the handout and to try some of your own and add them in if they aren't listed here and you find them helpful. What do we have for our next slide? All right, we made it to the homework. I want to encourage you as I'm talking about this, please add in questions. We've got about 15 minutes left in the training, and as soon as we're done discussing homework, we're going to be moving on to our our last question and answer session of the training. So I have some homework for you guys because this wouldn't be DBT if you didn't have homework. Because what I tell my patients all the time and what I encourage you to keep in mind and practice yourself is that if you only practice skills for an hour or however long a week that you're in skills training and you never use them outside of skills training, I promise you they won't help you. These are skills that we learn not just for the heck of it, but because we're looking to improve how we use them in real life. Not that therapy isn't real life by any means, but it's a much more protected version of real life. So I have some homework for you guys before our next training. Hopefully it's not anything too earth-shattering. The first part is to find ways to practice mindfulness every day yourself. I'm trying to move my little box because it's covering me up. I'm having trouble reading it. Every day for 3 to 5 minutes. This does not have to be a meditation where you take 3 to 5 minutes out of your busy schedule to do this. It can be, but the definition of mindfulness is to be fully present in the moment on purpose, non-judgmentally. So you can do this standing in the line at the grocery store. You can do this when you're talking to your kids. You can do this when you're looking to see who's next on your schedule at work. There are a lot of different opportunities throughout the day to practice mindfulness. So that's the first part of your homework. The second part is that I encourage you to practice teaching some of the distress tolerance skills to your patients and note the results. I want you to bring feedback and questions for our next training session, and I will be working on how we can work around this unique remote situation we've got going on to be able to answer as many questions as possible and give some helpful feedback for people. So I want to encourage you to pick 1 or 2 or 5 of the skills. Don't overwhelm yourself, and practice teaching them and see how it goes. jump in the pool and get wet and see what happens. I want you to remember and to remind your patients that the skills will not help you if you don't practice them and use them. So I'm not just encouraging you to do the homework, I'm encouraging you to remind your patients of this as well, to be practicing these skills in different settings at different times, to be curious about times when these skills can be helpful. All right, I think we are through the slides. I do want to note in closing, before we get to the questions, that if you check out the website for behavioral tech, I'm not affiliated with them in any way. I just received training from them and they were fantastic, and they've got some really great resources available. Check out their website. They offer a lot of in-person as well as remote learning opportunities for a huge amount of CEUs, some of them, and it's a really great resource that's out there. So questions. I think I already shared the stress cycle podcast. And so I'm going to move on from that. The next question was, not sure that I grasped the usefulness of the cat head drawing exercise. Could you explain how you review one's feelings while doing it and how it relates to skills training? Great question. So just because this is one of my favorite activities does not by any means mean that this is going to be everybody's favorite activity. And this can be a really bizarre and awkward activity to do. I'm going to say that this is an activity that draws on the participate skill pretty significantly. Because the act of drawing on your head is something that you kind of have to focus on, right? So it's a huge participate skill. It's also very much draws on the observe and describe skills in terms of recognizing, like, I felt really awkward about doing this activity. And I was also really curious what other people were thinking about it. And I was a little worried to look at what I was drawing. And I was having thoughts of, like, gee, I wonder what other people are feeling about this right now. That's one example of a way that I might process this with people. And just like when we work out, and we lift weights and we do push-ups and sit-ups and stuff like that, those things are uncomfortable. They're not fun. They're a little ridiculous. Like, if somebody videoed us doing it, we'd feel ridiculous. And this is one of those things. And it's one of those things that I kind of love because it's ridiculous, because it allows us the opportunity to laugh at ourselves and to laugh with other people who are having a similar experience. So I hope that that answers your question in a helpful way. Next question that I have is, I found that really powerful embracing sadness as a part of radical acceptance. Sometimes working with kids, we can gravitate toward fixing emotional experiences clients have in the moment. This can be a reminder to step back from that impulse. Absolutely. Allowing our patients and our colleagues to feel the emotions that they're feeling without feeling fix everything. That process of being present with the sadness that might come from radical acceptance is a really, really important part of the process of practicing radical acceptance and of coaching and guiding our patients through that practice. let's see, I've got another question. You said that something does not have to be radically accepted if you can do something about it. But the manual says that in order to do something about a situation or crisis, you first have to radically accept it. So did I misunderstand your point? Awesome question again. Yes to both. So in order to do something effectively about a situation that we are in, we absolutely first have to accept that we are where we are. And that might look like a really big process, or that might look like a brief acknowledgement, and both can be radical acceptance. I have to be really clear that I am here right now where I am in order to chart a path forward. And if I am in a place right now that is very uncomfortable and not where I want to be, and there's something that I'm aware of that I can do to resolve that, yeah, I got to acknowledge that I am where I am to move forward. And I don't need to radically accept that I'm always going to be there, because I can do something about it. So I think both can be true. And I might to go back to the example of needing to pay the bills, I might need to radically accept that I haven't paid my bill yet in order to get to paying it. And I don't have to accept that I'm never going to pay the bill just because I haven't paid it right now. I hope that doesn't muddy the waters more than it helps. Hopefully that clarifies things a little bit. And I really love that you guys are wrestling with this stuff and are asking questions that are important about it, because that tells me that you're thinking about it critically. And the more that you can talk about it and wrestle with these ideas, the more that it's going to seep in, and the more that you're going to have kind of a better idea of what's actually going on with these skills. I had an additional question. Would you please restate the title of the book on the stress cycle? So the title of that book is called Burnout. Subtitle is The Secret to Unlocking the Stress Cycle. And actually, if you look at the cover of the book, it's black and it says like burnout, 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 burnout. And that is by Emily and Amelia Nagoski, Nagoski. I think I got my copy on Amazon for less than $10. That was a pretty great buy. So I hope that helps. Let's see. I really appreciate the feedback, getting some appreciation for the slides and the integration of experiences. So thank you very much for that. I really appreciate that. If there are any other questions, please feel free to type them in. We got about 3 minutes before we have to close up. I want to say, let's see. I'm going to finish that thought and then I'm going to answer one more question. I want to say that I really appreciate having this experience. This has been a labor of love for me to put these trainings together. I had to do a lot of radical acceptance myself as I was putting this training together in particular, because it was so much harder to put together than I anticipated at the outset. And I really have enjoyed today's experience, and any opportunity that I can get to spread some DBT dust around the community is something that is an opportunity that I love to be able to take, because these skills are powerful and they give us options for helping our patients in ways that we wouldn't have otherwise. So I'm really appreciative of this opportunity, not only from Care Compass Network for reaching out to me to do this training, but also for you guys as attendees. I had one other question that I want to address, saying, is there any required reading we should be doing before the next training date? Yes. So this is my first time doing this type of a training, and I'm learning things as I go. And one of them is that when we put the training out to begin with, it would have been super helpful to be clear about like what people needed to read ahead of time and what would be helpful with that, because reading takes time, right? I'm sure you're not all just sitting around like twiddling your thumbs all day. So for our next training, I encourage you to review the first section of the skills training manual. I'm just looking this up right now. The part 1, an introduction to DBT skills training. It's a lengthy section. If you can get through it by the end of the 3rd training, awesome. But I encourage you to review that as much as possible between now and the end of the 3rd training. Our next training is going to focus on emotion regulation. And I'm going to pick up the slides that I didn't get to this training on clinical foundations, as well as adding in some additional stuff around that. So I encourage you to read the sections of the skills training manual also around teaching the emotion regulation skills, and review the handouts and worksheets for the emotion regulation skills.